All right, good morning. Assalamu alaikum. Sabah al khair. I think it's about time to start. We gave 5 minutes chance for people to start coming, and I think they will probably keep coming as we go. I'm replacing Dr. Badr Al-Ghamdi this morning as a chairman of this session, as his mom in ER. He's with her, had to be with her. It's my pleasure to co-chair this morning session with Professor Hassan Naimat. He's a pulmonologist from Cleveland Clinic, Abu Dhabi. And it's all about mostly group 3 pulmonary hypertension this morning. And the first speaker will be Professor David Kelly, and he will be talking about PH associated with the chronic lung diseases, the right heart cath, timely diagnosis for these patients, and potential screening for PH-ILD. David?
Well, thank you very much for the very kind introduction. It's fantastic to be in Saudi and get some great weather and hospitality. So my task today is to talk about pulmonary hypertension and chronic lung disease and making the diagnosis and the role of cardiac catheterization. And I'm the warm-up act for Luke Howard, who'll be following quite shortly. These are my disclosures. And what I want to talk about today really is why pulmonary hypertension is important in lung disease, when should one suspect pulmonary hypertension and perform cardiac catheterization, and then I want to finish with some take-home messages. So pulmonary hypertension, as we all know, is highly heterogeneous, and in this figure here, what we've tried to show is on the left-hand side, there are forms of pulmonary hypertension which are fairly rare, which we have targeted pulmonary vascular therapies for. But as we're all aware, pulmonary hypertension is much more commonly seen in the context of cardiac and respiratory disease, where the pulmonary artery pressure tends to be more modest and treatment is aimed primarily at the underlying cardiac and respiratory disease. Although, as we're all aware, a positive phase 3 study in interstitial lung disease has really refocused our interest on patients with underlying lung disease. So what's the scale of the problem? And in the ASPIRE registry here back in 2012, we did show that patients with pulmonary hypertension in association with lung disease had the worst prognosis of patients seen at a PH referral centre. And this was independent of other important factors such as age and disease severity. And when we fast forward now to the UK national audit from 2025 of nearly 27,000 patients who've been consecutively enrolled and 4,000 patients with lung disease. And if you're interested, there's an interactive dashboard where you can view this data. We can see that, very depressingly, that the median survival for patients with pulmonary hypertension and lung disease remains under 2 years. So this is an area really of very high unmet need. When we see patients with underlying lung disease, it's important to remember as well that the survival in pulmonary hypertension and lung disease depends on the underlying form of lung disease. And we can see that patients with sleep disorder breathing have a much better prognosis than COPD and also an ILD. And more recent data from our ASPIRE registry in a large cohort of over 700 patients having cardiac MRI imaging shows a very, very similar picture, again with patients with non-parenchymal restriction having the best survival and patients with combined pulmonary fibrosis and emphysema having the worst survival. So when we look at patients with lung disease, we need to make the diagnosis, we need to consider what the form of underlying lung disease is, but we need to spend a little bit of time thinking about what form of pulmonary vascular involvement patients have who've got underlying lung disease. And in this nice review here, I was involved with Karen Olson. Karen reminds us that dependent on our genetic predisposition and exposure to different environmental agents, particularly cigarette smoke, we'll develop a particular pattern of underlying lung disease, might be primarily airflow obstruction or parenchymal lung disease or a combination of both. And we'll also develop potentially some form of pulmonary vascular insult. And this might be related to degenerative remodeling, might be related to capillary destruction. And at the other end of the spectrum, we might see remodeling more akin to pulmonary arterial hypertension. So in the guidelines, when we're evaluating patients with pulmonary hypertension and lung disease, we need to consider what form of underlying lung disease the patient has, and we can see in the top panel here, COPD, CPFE, ILD, how much of a ventilatory limit do we have to exercise capacity, and at the same time, we need to think about how much pulmonary vascular involvement that the individual has, how much of a circulatory limit there is to exercise capacity. And in the panel at the bottom, you can see a rising line just showing increasing pulmonary vascular involvement. And in patients with lung disease, the severity of pulmonary vascular disease is defined by cardiac catheterization as a pulmonary vascular resistance of more than 5 Wood units. And of course, one of the challenges is which patients with pulmonary hypertension, lung disease we consider for treatment, and Luke will tell us a little bit about that later on today, along with Hoder and also Olivier Sitbon. So when we're in the clinic, when should you consider the potential diagnosis of pulmonary hypertension in your respiratory population? When should one consider cardiac catheterization? And I just want to highlight that there is quite a lot of published information out there in the form of guidelines, international guidelines. There's also the 7th World Symposium and also some excellent reviews. But when I'm sitting in the clinic and I'm seeing patients with respiratory disease, I think in particular when breathlessness appears to be unexplained or there's been a very significant change in breathlessness, and when I see people with COPD and severe pulmonary hypertension, their exercise capacity normally changes quite drastically over a period of weeks to months, so it's normally quite a precipitous decline in their breathlessness. We need to be very cognizant as well in our respiratory clinic when patients' breathlessness appears to be out of proportion to physiological abnormalities seen on lung function or on CT. And I think what's also important to remember is in a nice study from France many years ago from Ari Koud, he reminds us that in patients who've got lung disease and severe pulmonary hypertension, that over half of those individuals have got pulmonary hypertension unrelated to the lung disease with conditions like chronic thromboembolic pulmonary hypertension. So when you're in your clinic, you need to think about risk factors for PH, such as systemic sclerosis, and as we heard in this part of the world, lupus, portal hypertension, HIV, and also just ensure if patients are breathless and they have a history of previous DVT or pulmonary embolism, you consider chronic thromboembolic pulmonary hypertension. And then finally, if you're considering particular surgical interventions such as transplantation, one may wish to consider right heart catheterization. Now, respiratory disease is no different to other forms of pulmonary hypertension. The guidelines recommend echocardiography as the first-line imaging test, and no one in this room really needs to be reminded that, of course, when we perform an echocardiogram, we need to look at the TR jet velocity, but also integrate that with secondary echocardiographic features from the ventricles, from the pulmonary artery, and from the IVC and right atrium, and then come up with an echocardiographic probability of pulmonary hypertension. So how accurate is echo in patients with lung disease? And this is a landmark paper from the States, nearly 400 patients undergoing cardiac catheterization. And we can see in this study only about 40% of patients had a TR jet measurable at the time of their echocardiogram. We can see here in lung disease as well that echo tends to have a tendency to overestimate pulmonary artery pressure, although it can underestimate pressure. But generally, it's recognized that echocardiography is less accurate in patients with lung disease than in other forms of pulmonary hypertension. Of course, we make progress over time, and we heard from Hoder Terlo yesterday. Hoder does a lot of work with echocardiography. This is some data here from the group in the Brompton, showing that over time things have improved. And this is quite a selected group of patients with quite severe pulmonary hypertension, but echo-derived TR jet velocity was measurable in around about 90% of patients. And using this stepwise approach, it had relatively good diagnostic accuracy for patients with severe pulmonary hypertension. So echo is less accurate, but I think it's better in terms of assessing pulmonary vascular disease than has been suggested many years ago. Of course, in our respiratory practice, we will follow up patients with underlying lung disease with lung function testing. This is some data in patients with interstitial lung disease, and we can look at the relationship in the top panel there between mean pulmonary artery pressure and FVC, and we can see there's no significant relationship, but there is a relationship between gas transfer factor and pulmonary artery pressure. And that's not surprising because your gas transfer factor reflects problems in the airways, in the interstitium, and also in the vasculature. And in this quite old study here from Steve Nathan, I think it makes a very important point that as the gas transfer factor falls in patients with interstitial lung disease, we can see that the prevalence of pulmonary hypertension increases. And we know in our patients with COPD and mild airflow obstruction, our patients with emphysema, that severe reduction in gas transfer factor is a marker of significant pulmonary vascular disease. So reduced gas transfer factor is an important measurement and is a risk factor for underlying vascular disease. I'm very interested in imaging. We saw some really nice case presentations yesterday highlighting some of the metrics that we can measure. This is just to show that with contrast-enhanced CT, we can measure the pulmonary artery with quite a good degree of accuracy. We can also measure the right ventricular outflow tract, which tells us about hypertrophy, the RV-LV ratio. So there are lots of features on the CT scan that can alert us to the diagnosis of pulmonary hypertension. And of course, many of the scans that we perform in lung disease are performed without contrast enhancement, but we can measure the large vessels, the cardiac chambers. You can measure the volumes, for example, of the atria. Very difficult in non-contrast enhanced CT to see exactly where the septum is, but you can look at the tricuspid annulus diameter, maybe as a potential measure of the right ventricle. And ourselves and others are doing a lot of work with AI, and we can now automatically segment a lot of these vessels and cardiac chambers. So I think CT will be a very helpful tool in terms of diagnosis of pulmonary hypertension and lung disease. And of course, when we look at the recommendation from our international guidelines, we can see that pH is suspected. Recommended echocardiography, as I've mentioned, is the first test that we should consider. But I think really importantly, we need to integrate that with the results of other tests. And we heard yesterday the importance of not just relying on a single investigation. So that echocardiogram that doesn't show pulmonary hypertension, have a look at the CT scan, look at the pulmonary artery and the right ventricle, and look at those other measurements such as gas transfer. So it's also really important when we're assessing patients for pulmonary hypertension with lung disease that we optimize the treatment of the underlying lung disease, as this can impact on pulmonary hypertension, treatment of hypoxemia. And also, very importantly, if we are going to consider targeted investigations that Luke will discuss and others later on today, we need to make sure that we try and select the right type of patients. And I think referral to pulmonary hypertension expert centres is a really important part of that evaluation, particularly if you're considering cardiac catheterization. And we'd only really perform cardiac catheterization if we feel it's going to alter management decisions. So when we look at the Seventh World Symposium, you can see here that they talk about suspecting, detecting and confirming pulmonary hypertension. There's different domains, a clinical domain, so look at the clinical symptoms. There's a functional domain, your lung function test, biological domain, N-terminal proBNP, and morphological domain, look at your CT scan. And on the basis of that, using your Gestalt to come up with a sort of probability of pulmonary hypertension, and then if it's moderate or high, think about performing echocardiogram, and then you look at the probability of the echocardiogram. But you can see here, even if the echocardiographic probability is low, they recommend consideration of right heart catheterization. I think this really gets to the nub of the problem here in underlying lung disease, is that we lack well-validated non-invasive tools to aid the identification of pulmonary hypertension. So there are a number of different models that we can use. There's the Ford score, and based on retrospective review of different studies, including clinical studies of different pharmacological agents, we can see an AUC that we can achieve with these different index of around about 0.7. And of course, we're very excited by the FINDER study. This is a prospective study ongoing in the United States of America, looking at a systematic approach to patients with interstitial lung disease and then confirming or refuting the diagnosis with cardiac catheterization. And what's very interesting to me is this is the preliminary results just recently published, and looking at potential non-invasive predictors of pulmonary hypertension. This is 190 patients. And what is interesting is that the patients who had precapillary pulmonary hypertension had, for pulmonary hypertension physicians, very, very modest disease, SAPH2026, PVR 3.8 units. But what's interesting is there were statistically significant differences in gas transfer factor, echocardiographic measurements, and also in CT measurements. So I think this really does show, particularly with AI, we may be able to leverage a lot of this information to help to diagnose pulmonary hypertension using this non-invasive testing. And it's just also to say that investigators in this study were also asked to give their opinion in terms of what they felt the likely probability of pulmonary hypertension was. And you can see that we really weren't very, very good at identifying the presence or absence of pulmonary hypertension. So lots of work to do in this space, and this study is hoping to recruit just over 300 patients. So when we want to make the diagnosis of pulmonary hypertension, it's important, particularly when we're considering treatment, that we confirm the diagnosis with cardiac catheterization. And as I mentioned earlier, it's really important this is performed in experienced centers. It's a test that's very easy to do well, but it's a test that's also very easy to do badly. Important as well to perform the test in clinically stable patients, as acute exacerbations can significantly increase your pulmonary artery pressure over 30 millimeters of mercury. So we also tend to average rather than take the measurements at end expiration at the time of cardiac catheterization. This can, if we don't do this, this can tend to overestimate the pressure, particularly in patients who are hyperinflated. And of course, what's really important when we do a cardiac catheter is that we have a complete set of hemodynamic measurements. So we measure the pressure, the mean pressure, the wedge pressure, the cardiac output. And we can see in this patient here, mean pressure 48, a normal wedge pressure of 15, and a high PVR of 10 Wood units. And this patient has significant and what we would define as severe pulmonary hypertension. It's always important as well to look at the imaging, look at the left atrial size, and don't make a decision just on the results of right heart catheterization. And although we hold a lot of stall in terms of using hemodynamics to define disease severity, and pulmonary vascular resistance is a very useful and helpful tool. Many of us in this room are very interested in imaging. Roberto Bagliaglacca, Hoda Tello, myself, and there's a lot of evidence now that we can refine risk stratification in PAH by looking at imaging and right ventricular function. And this is some unpublished data from our ASPIRE registry in patients having cardiac MR imaging, showing that in patients with a low pulmonary vascular resistance, less than 5 Wood units arbitrarily defined, that those patients who got impairment of right ventricular function have a significantly worse survival. So we don't want to rely on just a single measurement. So as we sort of wind up now, I think one of the very important aspects, and maybe one of the elephants in the room in lung disease, is do we need to consider how we change our diagnostic approach in pulmonary hypertension in patients with lung disease. So I like to have all the imaging, I like to have the results of right heart catheterization, but is this really achievable in patients with lung disease? And it's a very, very common condition. And this is some data I was involved in obtaining, just recently published with John Wirt from the UK. We looked at a database of about 30 million adults in the UK, less than the UK, half the UK population, and we looked at the annual incidence of pulmonary hypertension and lung disease. And you can see that the annual incidence in lung disease, group 3 PH, is around about 70 cases per million population, and that translates into 4,000 new cases of PH in association with lung disease each year, and that equates almost identically to the number of patients that we see in our PH centres and our national network each year. So it's a very, very large potential burden, and we can see here that the average survival of patients with PH respiratory disease here just under 2 years. So this is a population of patients that triangulates very well with the published literature. So I think to the community, we need to ask ourselves how we ensure that we've got clinical pathways that are fit for purpose, that allow a timely diagnosis. How do we start to ensure that we have adequate access to right heart catheterization? And I think in the future, can we think about using non-invasive techniques maybe to select patients for targeted pulmonary vascular therapies? I don't think we're oven ready for this yet, but I think it's a goal that we might be able to work towards in the future. So in terms of from a diagnostic perspective, what
in survival of somewhere around 2/3 of a year. So that's how we got to that point. So we now have our clusters of patients that we might consider treating. So this was a lovely slide from Gabor Kovacs back in 2018, which conceptualizes where we think these different clusters of patients are. I've put here the PVR cutoff of 2 Wood units for the definition of precapillary PH, 5 Wood units for severe PH. So we have 4 clusters of patients now. We have our very clean IPAH patients who have absolutely no lung disease on lung function or CT. Then we'll have the slightly messy patients who we classify as IPAH, but they may have some lung comorbidity. And then we have our severe group 3 PH. And below that line, we'll have the non-severe group 3 PH. Now, Is 5 the right cutoff? Who knows? Well, in some data that I'll show you a bit later from the INCREASE trial, the patients given inhaled treprostinil showed that there was a benefit with a PVR cutoff considered at forward units. So maybe forward units it might be a cutoff for therapy. So that's who we should treat. Now, what about treatment? And before I get into the evidence from the INCREASE trial with inhaled treprostinil, I talk about what are people actually doing in the real world, because we don't have access to inhaled treprostinil in the UK. It doesn't look like we're going to be getting it for some time, and many people around the world don't have access to it. So what are people doing? So a few years ago, with the help of Ferrer, David Montani and I and a number of other colleagues were charged to do this survey around Europe to look at real-world management of PH-ILD. So clinicians were asked, first of all, about their current therapies that they would use for the actual interstitial lung disease. And so on the left, you have the proportion of clinicians using these types of therapies. So you can see there were many many clinicians actually managing the ILD. So most of them using therapies such as immunosuppressants, antifibrotics, anti-inflammatories, rituximab, and much fewer proportion using TNF inhibitors. And then there are a group of people who don't know what they're using, which is always a little bit concerning. You normally have to know what you're writing on the script. And then on the right-hand side, there's the proportion of patients receiving these therapies. So again, we go through the categories of antifibrotics, anti-inflammatories, and immunosuppressants, and only a small proportion of patients receiving rituximab and TNF inhibitors. Then if we switch to the pH therapies, and this is looking on at the actual patients and what proportion of patients are receiving pH therapies. So on the left with all the dots, that's all the countries bunched together. And then you can see that roughly everyone's kind of doing the same thing apart from the Germans. Who are giving a lot more therapy to their PH-ILD patients. So that's perhaps the only difference really between the countries and what they do. What are people using? This is not surprising that most people tend to be using the PDE5 inhibitors, sildenafil and tadalafil. And then there are still quite a high proportion of patients, in my opinion, being given bosentan, ambrisentan, macitentan. Of course, bosentan with no evidence from a study that was done a long time ago, led by John Wirt at the Brompton, and then ambrisentan, which showed worse outcomes, and then macitentan, which again has no supportive evidence. Then we get to the prostacyclin therapies, and you can see there's a small sample there of people using epoprostenol, iloprost, and then of course treprostinil, a smattering of selexipag patients, and then I don't think this was intentional that the riociguat was in red, but a small group of patients receiving riociguat, which, as we know from the RISE IIP study, showed a signal for increased mortality with riociguat. And this was the general approach that people would take. Their first-line choice in the majority, nearly 80%, was with a PDE5 inhibitor, and then the second-line choice, if there was a failure of first-line, about half the clinicians would say, I'd stop at PDE5. The other half would add in an ERA. A small proportion would start with an ERA, and a similar proportion would start with a prostacyclin-based drug. And if that failed, then there will be no additional therapies. So that's what people are doing. Now, does it work? Well, this was a very large study, and one of the many that have come out of the recent Go Deep registry in collaboration with PVRI, led by Werner Seeger. And I was scratching my head looking at the stats at this last night just before going to bed. I think I've got my head around it. But here's the consort diagram, and you can see we start with a sample of 34,000 patients, and from that there are 361 with idiopathic interstitial pneumonitis, pneumonia, and about two-thirds of those, 216 of those have IPF, and 145 have IIP, non-IPF. And so looking at this population, you can see on the top left, there are actually two lines at the top. They don't separate. One is IPAH and one is PAH. And then on the bottom curve showing much worse survival is IPF, pulmonary hypertension. So I'm showing here the 216, the slightly smaller subset where there was a slightly greater signal. On the top right, you can see validating the PVR cutoff of 5 Wood units. And on the bottom left, you can see PVR less than 5 Wood units, but treated with PDE5 in blue and untreated in red. So there is a statistical difference there, but when you then correct for other factors, that doesn't come out as being positive. And on the bottom right, you've got in the yellow line, that's a comparer data set of patients all treated with PDE5, and then you've got the blue and red as before, showing a statistically significant difference. And when you correct for the immortality, so time bias, on the bottom left, you can see that patients treated with a PDE5, it's only when the PVR cutoff is above 5 Wood units that you see a signal towards improved survival. What about the prostacyclins? So far fewer patients in this cohort were treated with prostacyclin-based drugs. On the left, you've got anybody treated with inhaled prostacyclin versus not, and there was a statistically significant improvement in survival. And then on the right-hand side, you've got patients who are treated, a comparison of PDE5 monotherapy in blue and combination therapy, PDE5 and prostacyclin in red, again showing a significant difference. Again, with smaller numbers, you've got 24 patients, so about 10% of the cohort being treated with dual therapy. This is supported by some further evidence published from the Royal Brompton Hospital, again looking at PDE5 and showing roughly a 1-year difference in survival. And interestingly, in this group, and I think this speaks a little bit to the fact that we didn't see a difference in survival with the old definition of severe pulmonary hypertension with ILD. The patients who seemed to survive better were those who were treated with a PDE5 with a normal TAPSE on echocardiogram. So actually what you really want to be doing is not waiting until the right ventricle is severe to identify your patients who are going to benefit from therapy. You want to be getting in and treating early. So the PVR cutoff is obviously the important thing. So now we come to actually where there is evidence, and this comes from the INCREASE program, which was in inhaled treprostinil, which was run a few years ago now and published in the New England Journal in 2021. And it's worth briefly looking at the inclusion criteria so we know who we're talking about. So these are obviously adult patients with group 3 PH on CT. They could have any form of interstitial lung disease or even CPFE, combined pulmonary fibrosis and emphysema. They had to have a right heart cath within 1 year, and they had to have the old definition of pulmonary hypertension with a cutoff of 25 millimeters of mercury and a PVR of 3 Wood units. They had to be able to walk more than 100 meters, and they had to be on stable antifibrotic medication. And if they had connective tissue disease, they had to have an FVC of less than 70% so that you weren't just picking out people, say, with pulmonary arterial hypertension. The primary endpoint was met, as you probably all know, with a 6-minute walk difference, placebo-corrected of 31 meters. And as I showed you already, this cutoff of 4 Wood units seemed to be where the benefit started to be seen. Looking at the secondary endpoints, these supported the primary endpoint, so there was a significant drop in NT-proBNP, and there was also a delay in time to clinical worsening, which consisted of hospitalization, a decrease in 6-minute walk of more than 15%, death from any cause, or lung transplantation. Quite a lot of adverse events. About a third of patients had to withdraw from the the study because of adverse events and serious adverse events. You can see 53 out of 160 in the inhaled treprostinil group, and in placebo, it was over half had serious adverse events. So this is a sick population, as we all know. Cough was the most prevalent side effect with 44%, but if you look at the placebo group, it's 33% because, of course, these patients will have a lot of cough because of the underlying disease. And this is the separation of the curves for the time to clinical worsening, the first worsening event with a p-value of 0.04. But we all know that the first event is often a lead-in to multiple events. So if you actually do a multiple event analysis, and so whatever the first thing is, you would then trigger another event, but of course this is then officially outside the study if it leads to a withdrawal. And this shows that with continued inhaled treprostinil use, there is a significant sort of accumulation, or rather prevention of an accumulation of events when people are on persistent placebo. So it's important to pick these things out, and you can see the green bars on the right represent death, which will happen maybe as a second, third, or even fourth or fifth event after the first one. So this is the only real fly in the ointment as far as I'm concerned with this study, and the one slide that I would struggle to explain, so I'm not even going to try, was that when the patients go into the open label extension, and so you've got the absolute 6-minute walk distance on the left, and then the mean change relative to baseline on the right, the patients who switch over to drug after placebo do absolutely nothing. And this has been thought to have been related to the fact that there's a delay in treatment, which means that the patients don't get any benefit. I do find that difficult to explain. But if you look at secondary endpoints, when people are switched over to inhaled treprostinil, there is a drop in NT-proBNP, which I always like that as a biomarker. There's nothing you can do about it. You can't fake it. It's not like a 6-minute walk or a functional class assessment, which there will be patient factors involved. This is simply a lab draw. So that's reassuring. Now, there was a surprising finding, maybe not surprising to some, but certainly surprising to many, and certainly to me, that actually, in a post hoc analysis, there was a clear difference in the FVC progression in patients who received treprostinil versus placebo. And this was even more marked in patients with idiopathic pulmonary fibrosis. And in fact, you even see an increase in FVC. I mean, that's just almost unheard of in interstitial lung disease studies. So the investigators and the sponsors took this forward into a dedicated study. I'll show you the open label extension data first, and you can see in this instance actually that there is when people switch over to drug, there is then an improvement in FVC, and I think we can potentially maybe bring this up in discussion if there's interest. The greatest response was seen in the people with the most severe pulmonary vascular disease, so the higher PVR and the higher NT-proBNP. So could it be something to do with a change in lung compliance if you've got higher pulmonary vascular resistance, or is it an antifibrotic effect? So the sponsor took this forward into a program, Teton-1 and Teton-2. Teton-1 is North America, and that's not read out yet. It's not completed, should be completing about now. And Teton-2 was from the rest of the world. Patients aged 40 or above with an FVC of more than 45% on antifibrotics with a diagnosis of IPF with a CT in the last 12 months. And this was presented at the ERS last year, and the findings were confirmed, which is very reassuring. Now, whether or not this looks like it's a disease-modifying effect in terms of being an antifibrotic or not, who knows? But we're seeing a longer time course here, but a significant, almost 100 ml difference between the two groups. This was seen in patients on background therapy as well as on no background therapy, with a really large difference in patients receiving background pirfenidone. And also, there was a difference in the progression in terms of DLCO. So I think that kind of makes sense to us in terms of progression of fibrotic lung disease and pulmonary vascular disease. So I'm going to stop there, and I'm going to hand over, because I think, watch this space. There are other inhaled treprostinils out there which are being studied. So Eutrepia, which is a 4 times daily dry powder inhaler using this novel form of technology for as a dry powder for to increase lung deposition and potentially lung retention. TPIP, which you heard about yesterday with, I think it was Jean-Luc talking about PAH, is also a program for that about to start in phase 3. Inhaled seralutinib, which Hoda's going to talk about, the Serenata study, will be opening up for that very shortly. And then with the FOCUS study, inhaled mosliciguat, an SGC activator, and that has just completed enrollment, so we should be hearing about the results, who knows, maybe towards the end of this year or the beginning of next year. Thank you very much.
Thank you, Luke. Elegant as usual. Thank you for this overview. So it's now my pleasure to introduce our next speaker, Dr. Khodr Tello from Gießen, Germany. I give Khodr this talk, which has limited data, very difficult task. I'm sure he will handle it very well. It's going to be about inhaled seralutinib in PH-ILD treatment, potential 2 targets in one. Khodr, welcome to SAPH.
Assalamu alaikum, rahmatullahi wa barakatuh. I think it's a great pleasure to start a presentation in Arabic as native Arabic. This is the first time. Thank you very much also to give me the opportunity to be the first time in Saudi Arabia. And it's also a great pleasure to talk about inhaled seralutinib in PH-ILD treatment and to discuss with you whether this might be a potential 2 targets in one. So these are my conflict of interest. I think it has been mentioned several times in the first 2 talks that we have this very common disease in pulmonary hypertension with group 3 PH and among those ILD PH, but we have an unmet need in those patients. And this is despite the fact that we have, this has been shown, a poor prognosis in their patients as compared to PAH or PAH non-IPAH patients. So we have severely ill patients, but we have an unmet need in terms of therapy for these patients. So this is dependent on pulmonary hemodynamics, so with a cutoff of 5 Wood units, as mentioned. And as clinicians, we are told to look for our patients, as David mentioned earlier this morning, to see whether they might have a complication of pulmonary hypertension or not. So to look for the echo, right atrial area, very simple measurements, 6-minute walk testing, CT imaging, pulmonary functional tests, VQ scanning, and to define whether there is pulmonary hypertension or not. But the problem is how to treat those patients. And we should also do the right heart cath in order to define severe pulmonary hypertension, 5 Wood units, which might give us an idea about the vasculopathy the patients might have. And in order to be able to say, okay, there is a remodeling of the pulmonary vessels, which is greater than the fibrotic part, and these patients might be eligible for treatment. So we should think of, are there some worsening symptoms which might be rather due to this vasculopathy rather than the fibrotic part? Do we have a very severe pulmonary hypertension with PVR greater than 4 Wood units, mPAP greater than 25 millimeter mercury, in perhaps a vascular limitation in CPET, elevated NT-proBNP, or non-severe fibrotic ILD on CT. So is the vasculopathy greater than the fibrosis in this regard? And then we should think of start medication, although we do not have an approved drug in order to start a medication, at least in most parts of the world. This is the idea, or this was, as mentioned by Luke, the idea behind this analysis. So just to look, if the centers start medication, what medication do they start, and does it really help? And this has been shown. There is a risk reduction of 46% when the centers start PDE5 inhibitors. Of course, it's retrospective, but We did a lot of analysis, so landmark analysis, sensitivity analysis. We excluded immortal time biases. And so the finding of this study was when they start medication in PVR higher than 5 Wood units, this is something which perhaps might help, but perhaps might help. This is not the gold standard of studies, this is retrospective. But, and I like this review by David Kiley and Karen Olsen, they summarized all the studies over the time which should be regarded as gold standard, prospective, randomized controlled studies. And you can see that there are a lot of different values here. So some of the studies were based on echo, the others were based on hemodynamics, but totally different values of hemodynamics. And what we can say is that all the studies, or the majority of the studies, didn't meet their primary endpoint. And some of them even were stopped prematurely because of harm of the patients even. And despite one study, so this was already told by Luke, the INCREASE study. And I really wondered why do we have one study which was positive in comparison to other studies which were not? Are we able to learn from this study for future studies? So what was done better, in a better way in that study in comparison to the other studies? Well, first of all, it is an inhaled administration. So I think this is very important to consider. So this is inhaled. And Adi Gofrani is in the room. He was very young in 1999. And he already was involved in that study from Gießen, where inhaled iloprost was tested. Inhaled iloprost was tested in already IPF patients, at that time classified as IPF patients. And the idea was from Adi and his colleagues and Horst Olszewski and Werner that inhalation might maintain VQ matching. So they measured it also with gold standard multiple inert gas analysis. And they were right. So VQ matching was maintained, whereas when apoprostanol was infused, there was a high shunt flow on those patients. So it seems to be that inhalation might be the right way to treat the patients in ILD-PH. So this was shown. Inhaled treprostinil was administered. It met the primary endpoint with the 6-minute walk. Luke told us this. And the important point is that if you just look at the baseline table, we have the majority of the patients with IIP. Among those, IPF is the predominant disease. So those are the patients we would like to treat. And the primary endpoint, but also the right ventricle was unloaded, anti-proBNP dropped, clinical worsening was improved. Luke showed us these data. I just want to show it again because this was something I was really surprised to see this data. So I didn't believe it, to be very honest, because I just thought, okay, this might be only perhaps a reduction of congestion, an improvement in lung function, and this could be something which is perhaps also clinically not relevant, because if you just look at the absolute values after 8 and 16 weeks, we talk about a difference of 28 milliliters, which was not significant, or 44 milliliters. But when they looked at the FVC predicted, in percent predicted, then they saw a difference of 1.8, and this was significant. And I was nevertheless, I thought, okay, this is an improvement, because when you are a pulmonologist, then you look at the other studies, at the approval studies for pirfenidone and nintedanib, and of course you all know that we slower the decline of FVC, but normally we do not increase the FVC in the studies we know. So, but if you just saw this, I was really, I wanted to see more data in this regard, and this has also been shown, but I just like to show it again, because after 52 weeks, which is normally period which we have in IPF studies, those were IPF patients, there was a difference of 95% in 1 year, 95 milliliters in 1 year, which is considered as really clinically relevant. So from the lung function way to look at it, it also might have an antifibrotic impact. So, and this is, I think, this is something I didn't expect from Teton 2, and this is something really which also surprised me. When you talk to people, I think to have opinions from experts, when I talk to Andreas Günther from our center, then he tells me, I believe in antifibrotic impact of treprostinil. Others say, I think it's only an improvement in lung function. So when you talk to Martin Kolb and Steve Nathan, or they summarized it in this review, they say, okay, treprostinil might also have direct antifibrotic impact. So through interaction with IP receptor, EP receptor, DP, PPAR, and leading to the suppression of proliferation, reduction in ECM, and the suppression of collagen overproduction. So, which might be the keys to success in ILD-PH studies? So we have one positive study, but what did this study a little bit better than the others? So we have, it is able to treat precapillary pH, we know this. It is administered as inhalation. And this drug should have also an anti-proliferative impact. So perhaps this might be something we should consider in thinking of drugs which might be helpful. And when we look at seralutinib, then we know that seralutinib, I don't want to overlap too much with Olivier, is of course based on studies also from Gießen by Ralf Schermoli and Sony Polamsetti. We know that from this array analysis from 2005 that that in patients with PAH, the PDGFR genes were upregulated. Ralf, this was shown by Paul Yu, could show that inhibiting the PDGFR pathway reversed primary vascular remodeling, so it is able to treat precapillary pH. Ardi, again, showed this on the clinical side with his case report in New England showing that PVR dropped. We had an improvement in 6-minute walk and the functional class, and Olivier will tell us the IMPRESS study then was unfortunately stopped prematurely because of the side effects of subdural hematoma, but nevertheless we had a very good impact on hemodynamics in this regard. So it helps in precapillary pH, but Olivier will tell you more. In order to overcome these side effects, the safety concerns which occurred with imatinib, seralutinib is an oral inhalation to address the underlying disease, but also again inhalation. This is a very good part because just think of the MIGET and to overcome the systemic side effects with subdural hematoma. So two points which are very, very important in this regard. And it has a greater potency and selectivity as compared to imatinib. So we block PDGFR alpha beta, CSF1R and c-KIT, and thereby being able not only to address proliferation, but also inflammation and fibrosis. And so we have this inhalation, precapillary pH is fulfilled as two of the keys to success. And now is the question, do we have this anti-proliferation? There are not so many data, but some of the data were presented last year at ERS and PVRI. There are hints, very good hints in my opinion, which show us there might be some data in order to inhibit, as anti-proliferative drug. It's a very complicated word in English, to be honest, anti-proliferative, okay. Seralutinib inhibited release of profibrotic markers, so we have procollagen, fibronectin, which were reduced. Seralutinib also reduced the amount of TGF-beta-induced SMA expression, and this was the case in clinically relevant doses in IPF human lung fibroblasts. And this was comparable to nintedanib, a drug which we know that it is a true antifibrotic drug. And what was also interesting, based on the TORREY study, Olivier will tell you more about this TORREY study, is that seralutinib from the samples from the open label extension reduced the circulating ECM biomarkers, so including COL6A3, and we know that COL6A3 is cleaved under profibrotic conditions to release ProC6, and also the production of ProC6 in healthy human lung fibroblasts was also inhibited. So also again a very important hint that there is antifibrotic potential in this drug. And this was again as in comparison to nintedanib, a very good hint in that it does work, it might work. Going to the gene signatures, there were precision-cut lung slices, and the fibrogenesis induced by the fibrotic cocktail on these patients, and then seralutinib was added. And in that fibrotic cocktail-induced PCLS culture, seralutinib significantly countered fibrotic patterns by downregulating the genes which were associated with ECM. And looking at the pathway level, that we can say that the 3 out of the top 5 pathways that had been downregulated by seralutinib in TORREY were interestingly those who are upregulated in IPF in key cell types. So we are talking about, again, extracellular matrix, cell surface interactions, and collagen chain trimerization. So these are some data. I think, of course, these are some of the data. We are talking about 2 patients sometimes in precision-cut lung slices, about donors, but nevertheless, from the idea of seralutinib, how it works, how it should work, I think we have very, very good hints that it might also fulfill this criteria, not only to treat precapillary pH, it is inhalation, but also to have an anti-proliferative impact. So, and this paved the way to go a little bit, yeah, this is the one, to the Serenata trial in order to test this, a phase 3 randomized placebo-controlled trial to evaluate inhaled seralutinib for the treatment of pulmonary hypertension associated with interstitial lung disease. So this could be the way, if we compared it to one of the positive studies with the INCREASE study, which might be hopefully of success also for our patients, of course. This is the study which protocol, so there will be 1:1:1 randomization with twice the committee in order to do this inclusion criteria. I can understand the company in order to go for a study like this because, as I told you, these keys of success might be fulfilled and be able to have a potential for 2 or to be able to have a potential for 2 or to treat precapillary pH. So just think of the vasculopathy, but also to have an anti-proliferation impact on the patients. So with that, thank you very much, and look forward for the discussion. Thank you.
Thank you for the great presentation. For our last speaker for this session will be Dr. Oliver Sitbon, who will talk to us about role of tyrosine kinase in patients with pulmonary arterial hypertension.
Oh, thank you very much. Thank you for your kind invitation, Abdullah, and I'm very pleased to be here. Now we will discuss not PH-ILD. I will discuss tyrosine kinase inhibitors in general and what I call a double-edged sword. And I will discuss not only tyrosine kinase inhibitors as a treatment of pulmonary hypertension, but also as a cause of pulmonary hypertension. Oops. That's my disclosures. Just to remind you what are tyrosine kinase. Tyrosine kinase, that's a specific type of protein kinase that exclusively phosphorylates tyrosine residues on target's protein. And those enzymes we can distinguish between receptor tyrosine kinase that play a key role in the regulation of growth factors, not only PDGF, of course, but some others, and non-receptor tyrosine kinase that plays a key role in intracellular signal transduction. And by phosphorylation of those proteins, this can induce an increase in cell proliferation and decrease in apoptosis. So it is a very good potential target, of course, for many, many diseases, not for cancers, and also for pulmonary hypertension. This is, all the tyrosine kinases are not the same, and the targets are very, very different from a tyrosine kinase inhibitor to another. Just an example of dasatinib and imatinib. As you can see, the targets are very, very, very different. Dasatinib targets much more receptors, than imatinib. All those tyrosine kinase inhibitors target the BCR-ABL, and BCR-ABL is very, very important in the chronic myelogenous leukemia. And if you look at the CML, the chronic myeloid leukemia, myelogenous leukemia, this is characterized by the translocation of chromosome 9 and 22, leading to a pathogenic signal transduction protein BCR-ABL. And we know that many tyrosine kinase inhibitors, such as imatinib, but also dasatinib, nilotinib, inhibit BCR-ABL. And this dramatically changed the prognosis of chronic myelogenous leukemia. Now we can almost cure the disease using tyrosine kinase inhibitors. But we also know that there are some side effects with this kind of drugs, like edema, musculoskeletal and pain, abdominal pain, diarrhea, nausea, etc. We also know that there are some pulmonary complications with tyrosine kinase inhibitors, in particular pleural effusion, we can see in particular with dasatinib. And we also know that pH may occur in patients treated with dasatinib. All those tyrosine kinase inhibitors target the PDGF receptor, and it's true for the tyrosine kinase inhibitors, but also for the multiple kinase inhibitors such as sorafenib. And we know that there is an aberrant PDGF signaling in pulmonary arterial hypertension, and we observed in those patients an increased expression of PDGFs and PDGF receptors in patients with pulmonary arterial hypertension. And this overexpression of PDGF and receptors drives pulmonary vascular remodeling, and experimentally we can inhibit the growth of smooth muscle cell using, for example, imatinib in some experimental models. However, when we talk about tyrosine kinase inhibitors, we cannot consider all the tyrosine kinase inhibitors as the same. And for example, that's what I call that a double-edged sword, because we have imatinib, which has been we use to treat pulmonary arterial hypertension, and on the other hand, we have dasatinib that can induce pulmonary hypertension. Let's start with dasatinib. We know that dasatinib is clearly a drug that is considered having a definite association with the development of pulmonary arterial hypertension. Beside aminorex, mafluorex, and others, we know the fenfluramines, dasatinib belongs to this category of drugs. But also bosutinib and ponatinib, which are other tyrosine kinase inhibitors, may be associated with the development of pulmonary arterial hypertension. And this is the representation of the pharmacovigilance database. You have you know the drugs like the fenfluramine and dexfenfluramine that with a definite association that has already been described, developing pulmonary arterial hypertension. But if you look at the tyrosine kinase inhibitors, we have dasatinib, which is clearly described having an association with pulmonary arterial hypertension, but also possibly for other drugs, not for imatinib. Let's start the story of dasatinib. Dasatinib was approved to treat chronic myelogenous leukemia in November 2006. And as early as 2008, 2 years after patient receiving the drugs, we observed the first case of pulmonary arterial hypertension. And then the year after, 4 cases, and the year after, 8 cases. So we have a regular increase in the number of cases. And in 2010, 13 cases of dasatinib treated patients have been developed pulmonary hypertension. So, and at that time, we estimate the pulmonary hypertension incidence to be around 0.5%. And since then, we observed regularly cases of pulmonary hypertension in patients receiving dasatinib, and it is the report in the French registry. In the French registry, we have regularly 1, 2, 3 cases a year of patients developing pulmonary hypertension after being treated with dasatinib. The evolution of pulmonary hypertension in those patients is usually good, and we observed usually a partial reversibility after dasatinib discontinuation. It's totally different to what we observed with anorectic drug, for example. And some patients, they improved just after this discontinuation. Some others need additional drugs, but overall, the patients improve after dasatinib discontinuation. And if we look at the long-term outcome, the long-term outcome is quite good. And we had a 5-year survival of more than 85% in those patients. Let's move now to imatinib. Imatinib, as you know, has been proposed to treat pulmonary arterial hypertension. And we know that the PGF signaling inhibitors can be used as a therapeutic option in PAH. It's true for imatinib. Imatinib has been shown to be efficacious in a phase 2 and also in a phase 3 study, but with some safety issues. And we will discuss also seralutinib. But let's start with the first attempt to target PDGF with tyrosine kinase inhibitors. It was with sorafenib. Sorafenib is a multi-kinase inhibitor that targets both PDGF receptor but also VEGF. And experimentally, in animal models, it works. As you can see here, sorafenib is very, very efficacious to reverse pulmonary vascular remodeling and to decrease proliferation and increase apoptosis. Let's go to human. There was a very small study including 12 patients with PAH on parenteral prostacyclin. It was on top of patients receiving an heavy treatment. And as you can see, this was a very small study, open label, 16-week study. We observed a non-significant increase in 6-minute walk distance, but also a decrease in cardiac output in those patients, and finally, no change in PVR. Imatinib has been shown to be efficacious in terms of improvement in hemodynamics by decreasing pulmonary vascular resistance, in particular for the most severe patients. And the study has been published by R.D. Gofrani 15 years ago. And this led to the launch of the IMPRESS study. It was a phase 3 study. And the phase 3 study of IMPRESS, we observed a nice improvement in the 6-minute walk distance as compared to placebo. However, due to serious adverse events that were very, very common, 33%, 1/3 of the patients discontinued on imatinib due to these adverse events, particular edema. We have also some case of subdural hematoma. So, and that at the end of the day, at the end of the study, finally, imatinib was not considered as a potential option to treat pulmonary arterial hypertension due to side effects. That's why imatinib has been developed also to be administered by inhalation, and this is the data from the Ayurveda study. You know, the Ayurveda, the people developed a drug that can be administered by inhalation. It was inhalation of imatinib at a much lower dose than the dose used by oral route. I remind you that in IMPRESS study, the dose was 400 milligrams once a day. Here, they compare 10, 35, and 70 milligrams versus placebo administered by inhalation. However, we know that since June 2024, we had a press release claiming that the drug did not meet the primary endpoint of PVR, and the study will be published. Now it is accepted in the Blue Journal. It is a negative study, but it will be published. And as you can see here, you have the change in pulmonary vascular resistance. We do not observe any change in pulmonary vascular resistance, neither on placebo, of course, but also on with the different doses of imatinib, 10 milligram, 30 milligram, or 70 milligram. We did not observe any change in PVR, and we also did not observe any change in anything. So, is it the end of imatinib? Not sure. This is the recent data that have been published by Alex Rossman from the United Kingdom. They try to show that giving imatinib perhaps at the lower dose, 200 milligram probably is the right dose. They observed a change in pulmonary vascular resistance, not pulmonary vascular resistance, total pulmonary resistance, because they use the CardioMEMS to look at the hemodynamic effect of imatinib. And here you have just an example of a patient. We observed a rapid improvement in the decrease in total pulmonary resistance. This is the blue curve here. As early as after 2 to 3 weeks, we observe a nice improvement in TPR, and this was maintained during the treatment with imatinib. But after withdrawal, we observe a slow return to the baseline value of pulmonary vascular resistance. So perhaps there is something to do with imatinib, but perhaps also at a lower dose. Let's move now to seralutinib. Seralutinib is a multi-kinase inhibitors acting not only on PDGF, but also CSF1R and c-KIT, as it has been shown previously. The drug has been developed to be given by inhalation. The Torres study was a phase 2 study of inhaled seralutinib in patients with PAH. 80 patients have been enrolled in that study. Interestingly, there were an imbalance with more functional class 2 patients in the seralutinib arm, and those patients were heavily treated, including 57% of patients on triple combination and 44% on parenteral prostacyclin. The study was positive with a 40% change in decrease in pulmonary vascular resistance. This was significant. It seemed to be more efficacious in the more severe patient, in particular the patient functional class 3. This is a change in NT-proBNP. We also observe a significant change in the NT-proBNP level, and also in the 6-minute walk distance, but only in patients in functional class 3 at baseline. In terms of adverse events, the drug was well tolerated. The main side effect observed was cough, but otherwise it was very well tolerated. In terms of open label extension, this is interesting because we observe a continuous improvement after the 6 months of the double-blind period, and for the patients receiving seralutinib, we observe an improvement after 6 months, but this improvement in PVR continues on the long term, and after 72 weeks, we have an additional effect, at least on the pulmonary vascular resistance, but also on the 6-minute walk distance. Perhaps we have to wait more time to observe a beneficial effect with the drug. The ProSERA study now is completed, and unfortunately I cannot show the data because I don't have the result. We will have the result in the forthcoming days, I think, perhaps next week, perhaps the week after, we will see, but unfortunately I cannot show you, and I don't know the results. So just to remind you what was the ProSERA study, it was a phase 3 study of inhaled seralutinib in patients with PAH. And interestingly, in that study, there was an enrichment strategy to select the more severe population, because we observed in the phase 2 that the more severe patients seemed to respond better than the others. And for this, we used either REVEAL Lite 2 risk score of more than 5, or an anti-proBNP of more than 300, or PVR of more than 10 Wood unit. And the primary endpoint was the change 6-minute walk distance, and we have a long list of key secondary endpoints. I don't want to go into too much detail on this. Interestingly, when we look at the screening failures, the main cause of screening failure was right heart cath or the REVEAL score. And otherwise, we have a different reason for screening failure. And this is you don't know those data, that the baseline characteristic of the patients are enrolled in ProSERA. In ProSERA, we enrolled 390 patients. Mean age was 50, a majority of female distribution in PAH classification, majority of idiopathic forms of PAH. And interestingly, look at the distribution of the functional class. We had 74% in functional class 3 and only 25% of patients in functional class 2. And this translates in the 6-minute walk distance, of course. The 6-minute walk distance at baseline was only 374 meters, despite the patients receive a heavy treatment, because more than half of those they have been treated with more than 3 drugs, including 30% on parenteral prostacyclin. And if we compare to the TORREY, for example, we clearly have a more severe population than the patient enrolled in TORREY, and the population is very, very similar to the population of the STELLAR study with sotatercept. STELLAR and HYPERION studies are very, very similar in terms of treatment of background medication, for example, for STELLAR, or in terms of 6-minute walk distance for HYPERION. Oops. So, what in the pipeline? Mark showed you that yesterday. In the pipeline, you have a different mode of administration for imatinib, and imatinib has been developed as a prodrug in order to mask imatinib gastrointestinal side effect. It is the AKT 001-201 phase 2 randomized trial that will start soon. And also another approach is to use an anti-PDGFB specific monoclonal antibody, and this is another approach that can be tested soon. So to conclude, TKIs not only inhibit PDGF and PDGFR, but are multi-kinase inhibitors. There is a definite association between dasatinib and the development of PAH. Oral imatinib reduce PVR and improve exercise capacity, but serious adverse events leading to an unprecedented rate of study discontinuation. And finally, inhaled imatinib study has failed, unfortunately, and seralutinib, it is a hope with seralutinib because it reduced PVR, and we will see what happened in ProSERA. Thank you very much.
Thank you, Olivier. Very nice talk. Please join us. Now we are open for questions, comments from the audience.
Very nice talk.
I have actually a question for the group, for the audience. So this is for David and Luke. So for patients, we identified that current effective therapy seems to help patients with a higher PVR 5 as a cutoff, we think of them. And we know that there are a lot of patients with ILD can come to see us with that gray zone. We know having pH, regardless of the degree of PVR elevation, carries a substantially higher mortality, median survival 2 to 3 years. So how do you approach them? And we know our clinical ability to predict PVR without repeating heart cath is very limited. So how do we go about monitoring or treating these patients?
I mean, I think it's a great question. I think it really just speaks to the point that we need more good clinical trial evidence in patients with PH and lung disease. I think that's the most important thing for the community to do, is to continue to do clinical trials. I think it is very difficult. The PVR criteria just identifies a group of patients with a particularly poor disease trajectory. And what we really want to try and do is identify people who've got treatment-responsive disease and treat them earlier. I think we see from the INCREASE study that using a PVR cutoff of 4, we see a particular benefit. So I think it was something that was identified particularly when there were no effective therapies, just to highlight people with a more significant degree of pulmonary vascular disease who might be more likely to have a pulmonary vascular limitation to exercise capacity. But I think it's a extremely challenging area, and I think we need more clinical trials. And I think it's very positive that the industry are very keen now to work closely with physicians to do more clinical trials. In my own clinical practice, we tend to limit, treating patients we don't have access to inhaled treprostinil. So we tend to limit the patients we perform cardiac catheterization in to patients we think are most likely to have more severe disease, and we base that assessment on lung function, echo, and CT. And then we decide to catheterize patients who we think have got more extreme elevations of pulmonary vascular resistance, or in patients that may alter treatment, such as patients being considered for transplant. But I think we need more clinical trials. Luke?
Ardi? Anything to add?
I've got
Sorry,
very little to add, but just what I tell patients is, look, we don't have any evidence for we don't have access to inhaled treprostinil. That's the only drug that has evidence behind it. So we don't have evidence for anything else. And therefore, in the hierarchy of the things I offer them, the next thing I offer them is a clinical trial. And if they fit the criteria for a clinical trial, I put them forward for that. If they don't meet the criteria, then I say we do have PD5 as an option. And just an interesting point that I've learned myself really over the last year or so, is that I've not looked so much at the echo or the BNP. And a patient I put into the FOCUS study just a couple of weeks ago had a normal echo, normal BNP, but he had a very high FVC-DLCO ratio, and he desaturated quite markedly on exercise. Cathed him, PVR of 7 Wood units. So that's messing with my head a little bit, because it means that there could be a lot of patients out there who you don't suspect on the basis of the echo or the BNP. And so I'm looking at those other features which I think came up in the FINDER study as well.
Speaking about the access, in France and Germany, do you have access to Tyvaso for ILD PH? You do? Germany?
We can order it with the international a program. So we have access. I tried it in I think approximately 5 patients. I think 4 of them terminated due to cough. So this is my experience. So I think I'd like to have, like I think Jean-Luc yesterday mentioned, better devices. Yeah.
Ardi?
Yes, first of all, congratulations to SAPH and the program committee for putting this session together with these esteemed speakers, because it was a very informative and enlightening session. I very much enjoyed it. I guess I have more a comment or an advice for developments in the field of inhaled therapies for pulmonary vascular disease and or interstitial lung disease, and the learnings just from what we saw presented here, failed studies, but also positive studies. When we consider inhaled drugs, the first thing we have to make sure is that the patients receive the drug in the region of interest, which is in the lung. So there has to be a preceding program optimizing devices as well as the formulations of the drug, making them reach the region of interest and being well tolerable. If the drugs don't reach the lung or the periphery of the lung, they cannot work. If the patients are not happy with the inhalations, the drugs will not work because the patients won't take them. So what, in my view, was a major flaw of the Aerovate study was that all that preclinical and also technical preceding work at the beginning was not done sufficiently. And this was displayed also in the fact that most likely the drug was underdosed at the end of the day. So when any company or we as a community consider studies to be done, we have to pay attention to all that work that has to precede the clinical trial, including technology of inhalation, including good characterization of the aerosol to make sure that it reaches the region of interest and patients tolerate it.
Thank you so much, Ardi. Any more questions, comment? Saad?
First of all, thank you all for your tremendous talk. I just have one question for Dr. David. What I understand that you said about 50 to 60% of echo has limitations in such patients. So still you will proceed with the right heart cath despite the numbers might not that helpful. And second question for Dr. Luke. We know that in medicine we don't have black and white. So what is the cutoff between saying we have to optimize the chronic lung disease and to start targeted therapy? Thank you.
I think there are limitations with echo. I think Luke has alluded to the fact that there are other measurements that are very helpful. Personally, I find gas transfer factor a really useful and underutilized medicine. It tells you about those 3 different compartments. So I think when you see a very low gas transfer factor with minor or moderate lung disease, I think you need to think about pulmonary vascular involvement. I personally find CT extremely helpful with or without contrast. I think when you give contrast, you can look at the pulmonary artery, you can look at the outflow tract for hypertrophy, you can look at the size of the cardiac chambers, and I think that's a very useful investigation. So that's what I use. I'm not saying it's perfect. I think FINDER will be helpful in ILD. I think COPD, I think we've got a little bit more work to do. But we know in patients with pulmonary arterial hypertension, there are fairly cardinal features that we can identify from imaging techniques. So at the moment, I wouldn't perform a cardiac catheter in a patient with underlying lung disease unless I felt it was going to clinically change management. So currently, we've got quite a high bar because we don't have access to a lot of treatments.
So on that second point, I mean, I think it's interesting, isn't it, that you've still got these patients with horrific-looking lung disease and very small amount of increase in pulmonary vascular resistance. And I don't know where the right cutoff is to say when you should start treating. And I would like to think that there should be, in your brain, you can kind of figure out that, look, there's so much lung disease here that the PVR of 3, 4, 5 Wood units is irrelevant. But actually, the more I look into this, the less I trust that instinct, really. And so, and I think we're seeing that drop from 5, maybe goes down to 4 based on the evidence, and certainly the trials are including people with PVRs of 4 and above. So I think we might see that gradually decrease, but probably still there will be those patients with severe lung disease with a PVR of 3 or 4 that aren't going to benefit from treatment. But you know, that patient's only got 1 shot, so we'll have to see. But I think you have to treat the treatable, but still with some clinical acumen. So it's a good point without a strong answer.
Great.
Thank you so much for this amazing session. I have a question about serlotinib. Dr. Oliver, if you can answer this question. I think serlotinib is one of the things that they tried it in the clinical trial.
Way in order to image the patients in functional respiratory imaging. I like it in order to see the distribution, how it worked, whether we have an impact or not. But the conclusion of the authors in order to show this is reverse remodeling, I'm not convinced of it. So this is my opinion.
I agree.
So I don't know what you say.
I strongly agree. And we don't know what will happen with other drugs because it's been never tested to use the traditional vasodilators in this kind of imaging technique.
There is actually data for muscle Segwat. They did also the same, and
Yeah,
it was also positive.
exactly.
We discussed that. Remember that?
And
Yes.
yeah.
Yeah.
But vasodilators are also anti-remodeling drugs.
So improving the hemodynamics, improving cardiac output, redistribution of the blood through the pulmonary vasculature gave it positive.
Can we rely on it as an indicator of the clinical improvement? I mean, can we depend on these outcomes rather than looking at the 6-minute walk test, BMB, alone as a clinical imaging, or we have to look at the other clinical parameters?
That was the answer, Sarah. I mean, it's an indication of improvement of the cardiac output, basically distribution of the the blood through the pulmonary vasculature, whether it's long-standing. Excuse me. It doesn't mean that there is actually improvement in the remodeling process because of sirolitinib. And it was, in fact, repeated in some other studies using different molecules, same outcome. I think we're like 5 minutes behind the schedule, and I know the next session is very exciting for many. It's going to be about CTEPH. So thank you so much for coming early morning, and we'll see you. It's supposed to be 10:45, but we'll give you another 10 minutes. So let's be back 5 minutes before 11, please. Thank you so much.
Thanks.
Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of my colleagues,
Can we have a seat to start the last session? So my name is Dr. Khalid Al-Abidallah. I'm a pulmonologist at Prince Sultan Military Medical City. It's my real pleasure to co-share this session with my dear friend, Dr. Anora Traif. She's a pulmonologist from King Faisal Specialist Hospital in Riyadh. So it has been a wonderful 3 days. We have learned so much. And I cannot think of a better way to end this wonderful conference than with such an interesting topic, SAPH. So Dr. Anora, she will introduce the first.
So we have a slight change in the order of the talks. It's my great pleasure to introduce Professor Irene Lang. She's a professor of cardiology and known figure in SAPH at the Medical University of Vienna, and she will talk about optimizing balloon pulmonary angioplasty, an update on the role of medical therapy pre and post the procedure. Prof. Irene, the floor is yours.
Thank you very much. Thank you for having me. I'd like to thank the organizers particularly, and I do agree this is the best of all. It's at the end. It's my conflicts of interest. So I'm going to focus in on group 4. This is just to give you an orientation. This whole session will be on pulmonary hypertension associated with pulmonary artery obstructions. It's also called chronic thromboembolic pulmonary disease with pulmonary hypertension, and that is SAPH. Keep SAPH in your brains. It's a pulmonary vascular disease that is defined by the lesions that it produces. It's webs, veins, occlusions, and tortuous lesions. I think this has really come from BPA to be much more systematic on the lesions. And this is an exemplary case where you can see much obstruction, but you can also see other lesions, like here, narrowing, here, another one, here, a web lesion. This is defined, I think, by the lesions. And over the years, the International CTPH Association has run registries that have informed the scientific community about chronic thromboembolic pulmonary hypertension. There was a first registry in 2007, another one about 10 years later. Then came the BPA registry, which was dedicated to first-time BPA procedures, almost worldwide. And finally, the third ICA registry that is ongoing, it's the TEAM registry. I think we have learned a lot. We have informed the guidelines. This is the treatment algorithm of the most recent 7th World Symposium on Pulmonary Hypertension. You are familiar with that. And the mainstays of treatment is pulmonary endarterectomy, balloon pulmonary angioplasty, that will be addressed by Professor Matsubara, and riociguat, PH medication. The approved treatments are riociguat and subcutaneous treprostinil. Let me talk in the beginning about what have we achieved. You see on this slide, the red line is the 3-year survival curve of patients without mechanical treatment in the first registry. If you look at patients in the second registry, no mechanical, look the same. But also in the second registry, those who were no candidates for pulmonary endarterectomy undergoing BPA are the purple. 3-year survival changed from 72 to over 94%. And this aligns very well with PEA, pulmonary endarterectomy survival. So I think we can say this is a reason to celebrate. SAPH survival has much improved. But what were the drivers? So there is, for this group of patients who are no candidates for pulmonary endarterectomy, there is BPA and PH medications. Let us dissect the role of both. So in the second registry, mechanical treatments were very clear predictors of better outcome. So the mechanical aspect of CTEPH is very strong. The BPA registry publication, as shown here, has demonstrated very dramatic improvements of hemodynamics worldwide in all the centers, 38% decrease in mean pressure, about 57% precisely decrease in PVR, at the cost of not so many complications. Nobody died, which I think is a good signal. This is a sub-study of the RACE trial that you are all familiar with. It's a different view, but if you look at metrics of right ventricular afterload, comparing BPA primary initial treatment versus primary initial medication, you see that the mean right atrial pressure, stroke work, and the rate pressure product, which is equivalent of right ventricular oxygen delivery, looks very good for the mechanical treatment. So in line with this thinking. So I think the game changer is BPA, and that has been shown in a recent work of a Japanese registry, where you see that the number of BPAs have increased over time, and so has survival. And I will show you another slide of this publication in a moment. So let me discuss. I had a debate with Adi Gofrani 12 years ago. Everybody should get Rio first, and I defended the mechanical. There was no data at this time, that was a face-to-face. He defended Rio first. So let me go back to this and maybe change the aspect. Anticoagulation, please do this immediately. And the slide that you are seeing below, and it's a guideline recommendation, and the slide that you are seeing below is taken from Professor Matsubara's work, recently published, where you see clot in the pulmonary arteries of patients previously BPA'd. And the message of the short report is half-dose DOAC in a previously BPA'd population may not be sufficient, may be sufficient for atrial fibrillation, long-term treatment, but not here. And I think it's a very interesting piece of evidence that chronic thromboembolic pulmonary hypertension isn't just clot. It's inflammatory thrombosis. It needs a broader anticoagulation, and yes, please first. So what about medications? The foundation for medical treatment is microvasculopathy. And in this work, we looked at the hemodynamic readouts of histologically proven very small vessel diameter, less than 200 micron changes. And we found that in about 40% of all chronic thromboembolic PH cases, regardless proximal distal, you get this type of microvasculopathy. And that's the building ground for medical treatments. This is what we think. And all these trials have looked at the change in PVR and mean pressure. And you see the change in PVR is modest, 25%. The change in mean pressure, about less than 10%. So the power is in the mechanical treatment. Marion Delcroix has analyzed in the second registry a sample of patients who underwent just medical treatment. And you can see that in this graph, the SGC outperformed all the other medical treatments. It's an interesting signal, but, and let me show you the Kiko publication, patients without mechanical treatments are becoming less and less common. You see, In the early days in this registry, was 60% had no mechanical treatment. Today, very few. So think about this medical only for a very small group who are really no candidates for pulmonary endarterectomy, no candidates for balloon pulmonary angioplasty. But you can pick them in the larger cohorts, very few patients. And we have also looked at this group. This is of one of my PhD students. He has looked at this only medical and found that patients who were vasoactive at the first cuff, they did better with medical treatment. I think it's an interesting small paper that I would like to mention here. But the group is getting smaller and smaller. And of course, medical first is part of a multimodality management. This is French data, where you can see in these 9 patients, baseline is blue, and there is an improvement of hemodynamics already after medical treatment. And this is being ongoing in France. They have another study. I will show you the impact study with upfront combination treatments. So do we combine BPA always with medical? That question has been addressed in the BPA registry. 70% were on pH-targeted treatments at baseline, 60% at follow-up. So it's a very commonly used strategy. Do we start before? Well, we have had this discussion. In RACE, one of the readouts of the extension study was that BPAs reached a 60 to 70% decrease in PVR, and it appeared to be safer if patients were pre-treated. And that observation made it into the guidelines as a 2AB recommendation. In modern registries, there was no signal for medical treatment improving survival, improving mean pressure. This is from the BPA registry, and most recently from the J registry. You see at the bottom the black box that there was no interaction with pH drugs initiated before the first BPA. So we don't really know for sure. And this is, as I mentioned, the impact trial design, where upfront MATSI plus RIO is compared with upfront RIO. So in Vienna, we have a practice. I show you a little table here of patients who come to my clinic. You see there's a treprostinil pre-treated, a RIO pre-treated, and an unpretreated group. And the treprostinil pre-treated is mainly females, frail, as you can see here, with a BMI of 23, very high proBNP, and down here, DPG 24, mean pressure 57. So the very frail women who have a high risk of complications, they are put by us without any data in an experimental setting on what we call the treprostinil bridge. And you can see here that there is no statistical significant difference, except when you look at this stage, which is, of course, preliminary. There seems to be a signal that they get a larger decrease of PVR. So, what about after BPA? And we have the opportunity to look at exercise data from Okayama, where you can see that patients who have reached a very low mean pressure after their last BPA session, they were either taken off RIO or left on RIO. And the performance in terms of exercise, cardiac output over mean pressure, was better in patients who remained on riociguat. How do we do this now? Well, please look at the team registry publication that is coming up. We have actually approached the end of the data collection. The inclusion is already completed, and I think it will be a reflection of current practice, and will be able to answer some burning questions that we have. however in a registry format. My summary is in 2026, we have a multimodality approach. I would like to emphasize again, chronic thromboembolic pulmonary hypertension is a mechanical problem. And we decide in a multidisciplinary team which is the initial treatment. Could be medical, could be BPA, could be PEA, pulmonary endarterectomy, depending on the patient. We see less and less medication-only CTEPH patients. And if you see this, ask the question why. So there's 3 reasons I'd like to list for the combination of medical with BPA. One is there is secondary microvasculopathy, and we can measure that. There's 2 ways, the upstream resistance hemodynamic curves that I showed you, and there is a recent imaging strategy to see microvascular disease published by Professor Rémi Jardin, where she looks at ground glass opacity lesions in the pulmonary parenchyma and predicts secondary pulmonary vascular disease with a cross-sectional diameter less than 500 microns, so not dilatable with any balloon. The second reason is to increase the safety profile. We have some evidence, but no powered randomized trials, and to increase exercise capacity of patients following BPA. That's nicely shown in the therapy hybrid BPA trial. I'd like to make you aware of the ICA meeting in Warsaw in this year. It will be completely CTEPH. Thank you.
Well, since Professor Irene Lang is leaving for her flight, we can take 1 or 2 questions.
Happy.
Any questions?
Warming up. No, it's not a practice. It was a study. The question was, is it state of the art to do vasoreactive testing? No, it isn't. We did basically an academic study to get more insight into vasoreactivity in chronic thromboembolic pulmonary hypertension. There's an old paper out in circulation many years ago, and we just wanted to know if this holds up. But I think the group that is interesting is just very small. Those are the patients who have no mechanical options.
Follow-up question. Now, medical treatment with some residual pulmonary hypertension after surgery, what's your personal approach? We know about the data, but what do you do normally since you have a big center in Vienna?
Great question, thank you. So the first is to do another angiogram and be certain that there is no dilatable targets left. And that is often the case after pulmonary endarterectomy. We love the surgeons, but we also show them where they missed out branches. And we also know that BPA is sometimes not done universally in all the segments. There's a lot of segments, a lot of possibility to overlook lesions. So I think first, get all the lesions done. If you can't get them done, and hemodynamics plus patient comfort is not in the green range, it's very empirical, you know, then we use medical treatments. And we try to, I shouldn't say that, because we try to stop medical as much as we can, but like to give it to other people, maybe in combination. But for the ones who are good, who have a normal pressure, less than 20, who have a normal life, or who are elderly and have a little residual, we leave them. We know that if the pressure is below 30, they live forever. And if it's below 40, maybe we look again for some BPA targets.
One last question, Irene. Now, after BPA has been established now as a treatment, now in your center, we know the Japanese data now. Is it taking over more and more cases instead of PAAs?
Yeah. There was a publication by Elie Fadel from the French group. I think is a very good summary that BPA is not as much in competition as we think, but there's more patients that were previously don't touch, no option. So we bring in the no option. So there is apparently more BPA, but surgery remains the same because the big clot goes to surgery.
Thank you, Prof. Lang. We really appreciate your great talk.
So it's a great honor to introduce the second speaker, Professor Hiromi Matsubara. Professor Hiromi is the Director of Department of Cardiology at National Hospital Organization, Okayama Medical Center. He's one of the main figures in the BPA field, and he will give us a talk today about 10-year survival and prognostic factors after BPA in inoperable CTEPH. Prof. Matsubara, the podium is yours.
Thank you for chairperson. Good morning, everyone. This is my second time to join SAPH. Last time was 2020, just before COVID. At that time, I also talk about BPA. At that time, all about BPA. My aim, I don't know the Professor Abdaran's aim, but my aim was to spread my knowledge and to try to start up the BPA in this country. But I was failed at that time. So this is my return match, maybe, and these are my disclosures. So at first, I have to explain the BPA. It's very simple interventional technique. At first, you have to find out the region and pass the region with the guide wire and dilate it with balloon catheter. Immediately after dilation, you can see the region, distal flow like that. It's very simple, very easy. The problem is there are numerous regions within the lung in CTEPH cases, so you have to repeat this for 18 segments and numerous subsegments. Okay, we reported our initial experience, outcome of our initial experience in 2012. At that time, we treated 68 patients with average 4 procedures, and in each patient, 12 regions dilated. As a result, mean peak pressure could be decreased from 45 to 24, but 60% of patients developed complication at that time. Currently, much less, but at that time, so many cases experienced, especially the hemoptysis during or immediately after the procedure. When we published this, actually, until the acceptance, it's need a much longer time. We have to revise so many, because not only surgeon, but even pulmonologists, cardiologists, all criticized us. It's crazy, they said. So I tried to publish our experience, and alongside the positioning of balloon pulmonary angioplasty BPA gradually improved, and in the final treatment algorithm, it positioned next to the surgery, much improved compared to previous. Also, I tried to accept all visitors from all over the world and try to support them and visit so many countries to start up the BPA program in every country. Please note that last year I could come here, not here, Riyadh, and could support the startup of BPA program in King Faisal Specialist Hospital. I believe the BPA in Saudi will get a great success in the near future. Of course, already succeeded, but probably will get much more. So nowadays, in many countries, I'm sorry, some countries I don't know, but in so many countries, BPA has been performed. So last year, international BPA registry, the outcome of international BPA registry published in that report. It's a global experience, but mean peer pressure could be decreased from 43 to 25, almost the same as our initial experience. So the global experience now catch up to Japanese experience, and PBR decrease also like that. How about 3-year survival rate? 94.1%. It's a patient, the inoperable patient, not the candidate for the PEA, but still have a very good survival. From Japan, last year also, we published the Japanese BPA registry results, and decrease of mean peer pressure also about 30%, from 36 to 21. And 3-year survival rate was almost similar for the international registry data. So the 3 years, 94.7 would be good and almost similar to that of PEA, the surgical experience, but still a bit shorter compared to the survival data of PEA, surgical treatment. Because we started this procedure in 2004, so we have more than 20 years experience of this treatment. But in European country, the first center that started BPA following us was Vienna, but that's 2014. So at most 10 years experience existing in the world. So this slide was presented in the 7th World Symposium, that long-term survival more than 10 years after PPA and its determinants have not yet been elucidated at that time, and still now on. So as I said, we started our program in 2004, and the French group started their BPA in 2014. So we have more than 20 years, and the French group has more than 10 years history. So we decided to collaborate, merge our data, and analyze the truly long-term survival and its determinant. So the inclusion criteria of the patient was SAPH patients initiated BPA from November 2004 to March 2023 in Okayama or French SAPH registry. And the exclusion criteria is registered in other prospective studies like LACE or Mr. BPA study. And performed PEA after PPA, it's also excluded. So the patient characteristics, the patient number was 1,013, and almost half and half from Japan and the French group. And as you can see, the female patients are predominant, 65%, mainly because of the Japanese patients are, most of Japanese patients are female. And associated medical conditions, please note that malignant disorders or proliferative disorders exist in about 14% of the patient. And the indication for BPA, mainly technically inoperable. And some cases ineligible due to patient's condition, meaning the too old or too frail to be considered as a surgery candidate. So it's an entire survival rate. Please note that the 3 years survival, 92.5, a bit lower compared to the recent international CTF registry or BPA registry or Japanese BPA registry last year's reported one. It is because we included all the patients. It's meaning during our initial experience, we have to establish the technique, and that in that period, the complication rate was much higher compared to current experience, but still included in this data. And for 5 years survival rate, about 90%. For 10 years, about 80%. It's almost comparable to that of PEA, the surgery. If we look at the differences in center, because up to now, Japanese data was too good compared to the international data, but we separately compared the survival data. And please note that there was no significant difference. The French group survival until 5 years appears to be even better compared to us because of the standpoint is a bit different from ours. But anyway, they're almost similar. So no center difference exists. And the reason for the BPA, so as you can see, only the patient with surgery ineligible due to the patient's condition, like too old or too frail, show the worse survival. Whereas the other reason, technically inoperable or residual pH after surgery or refusal of surgery, it's meaning that the operable cases. So orange line show the operable case, but patients refuse surgery. So we have to treat them with BPA, but still show the good survival. So the long-term efficacy after BPA, decrease of mean blood pressure from 41 to at first follow-up 25, and the latest follow-up for 23.3 without additional BPA or additional medication. PVR decreased from 7.9 to 3.6, and at last follow-up 3.3, also done without any additional treatment. So generally could show the maintenance of the good outcome after BPA after a long time. And from the baseline data, only two could predict the outcome. One is the history of malignant disorders. They are treated within the 2 years prior to BPA. Much older one is not influence the outcome, but within 2 years. And the baseline 6 minutes walk distance also could be a determinant of the outcome of BPA. It's meaning that probably the patient's condition before BPA, condition meaning the right heart failure or frail, would be influence the outcome. So regarding 6 minutes walking distance, the threshold value was about 300 meters. If patient's baseline 6 minutes walking distance less than 300 meters, the survival rate would be much worse compared to other patients. And for the malignant disease, survival rate was very poor. But it's because the death from the malignancy, the recurrence of malignancy, not from the pH-related deaths. But this cannot be a treatment goal. So we have to check the hemodynamics after the treatment. Among the hemodynamics after the BPA, as you can see, right atrial pressure and mean PA pressure could be the determinant of the survival. PVR also could be the determinant, but wedge pressure and cardiac output could not be a determinant. So the main driver for the PVR would be the change of the mean PA pressure. So we just include mean PA pressure. About right atrial pressure, differences are very small. So we just check the threshold value of mean PA pressure after the treatment. And as you can see, ROC analysis indicated that the threshold value should be mean PA pressure, the 30. But it's immediately after the last BPA. Probably some cardiologists could understand that immediately after the procedure, because of the influence of the contrast injection, usually the mean PA pressure a bit increased compared to without contrast. So waiting 1 day, 2 days, the mean PA pressure would be much lower, but immediately after 30. So for the initial follow-up, it's about 25. So almost near normalized of hemodynamics would be necessary to get a better long-term, truly long-term survival of the patient. So the patients treated with BPA showed excellent long-term survival with an 80% survival rate at 10 years. Patients ineligible for surgery due to their condition had the worst long-term survival. Hemodynamics in patients with BPA have remained improved long after BPA. Greater 6 minutes walking distance and absence of malignancy within the 2 years prior to BPA are associated with better long-term survival. Mean PA pressure less than 30 mm mercury at last planned BPA, and probably at first follow-up, maybe 25 mm mercury, associated with better 10-year survival in patients with technically inoperable CTF cases. Thank you for your attention.
Thank you, Prof. Matsubara. If you can join us here, we'll leave the question at the end.
Now it's my pleasure to introduce Prof. David Kelly. He's a pulmonologist and a professor of pulmonary vascular disease at Sheffield, UK. Prof. Kelly, floor is yours.
Okay, that's great. It's nice to see him from France. Anyway, thank you very much. That's fantastic. And it's really nice to share the stage with one of the real legends of treatment for chronic thromboembolic pulmonary hypertension, Hiromi. And my job here is to try and find Hiromi a little bit more work. So what I want to talk a little bit about is how we can potentially enhance our diagnostic approach to the patients with suspected CTEPH, and these are my disclosures. So I think we diagnose chronic thromboembolic pulmonary hypertension by having an integrated approach to how we follow up patients with pulmonary thromboembolic disease. And I think we follow up people with pulmonary embolic disease not just to diagnose CTEPH, but to provide lifestyle advice. And there's lots of other very important things that we do. So I want to very briefly just touch on the importance of acute PE follow-up. How common is CTEPH? We'll touch on some of the more recent sort of studies. And then what I'd like to do is just finish off by giving you our experience of running a dual speciality acute PE follow-up clinic with hematologists, and then very finally talk about how we might use radiology in the future to improve the diagnosis of patients with chronic thromboembolic pulmonary hypertension. So for many of us in the room here, this will be quite familiar. I graduated in 1991, and managing and treating pulmonary embolic disease was fairly straightforward. All you had really was VQ scanning, or you had to have a petition to get a single-slice CT pulmonary angiogram. If it was acute PE, at that time we call it a massive PE. You would thrombolize the patient. Otherwise, it was IV heparin, anticoagulation for 6 months for first PE, or recurrent PE, long-term anticoagulation. So it was fairly straightforward, but I've tried to condense everything into a single slide here, but the management of PE now is much more nuanced. We don't just rely on implicit judgment for the diagnosis of PE. There's a whole load of different risk scores. There's lots of different imaging modalities. We're diagnosing much smaller PEs. We risk stratify now to define our initial treatment approach. Got lots of different anticoagulants that we can use. And what's really important, I think, is the long-term follow-up. How long do we anticoagulate for? That's one of the most important things that we do in our follow-up clinic. Think about thrombophilia testing, cancer screening. I put CTEPH screening here as well, but providing lifestyle advice is really important for people following pulmonary embolic disease. So how common is CTEPH? How should I investigate for CTEPH? We've seen lots of different statistics over the years, ranging from 0.1 to 20%. We've now got 2 large prospective studies, both including around about 1,000 patients, the FOCUS study and the OSIRIS study, both showing a cumulative incidence of CTEPH of around about 2%, so 2 in 100. So what can we learn from these studies? So the FOCUS study was a very detailed study. So patients had a baseline evaluation. They were then seen at 3 months, 12 months, 1 year, baseline 3 months, 12 months, and then 24 months. And they had very detailed investigations, blood testing, exercise testing, echocardiography. And what was an interesting finding of those in that study is that many patients had abnormalities on echo, so lots of people got left heart disease and other problems, but they were associated with a CTEPH diagnosis only if accompanied by clinical, functional, or to a lesser extent, laboratory abnormalities. So I think it really very much makes the case for an important symptomatic assessment and really follows on from previous data showing that performing echocardiography in all patients following a pulmonary embolic event is not required. The OSIRIS study is quite interesting. I do like the questionnaire and the use of language, but this was a study where patients had a set questionnaire they had to answer. They had to answer some questions about breathlessness, have your symptoms resolved following a PE. Depending how you scored on the questionnaire, you had an echocardiogram. And really, I think the learning from this study is it does support a symptomatic assessment, again, when you're seeing patients with pulmonary embolism, to refine your choice of performing testing such as echocardiography. So in this figure here, what I've tried to show and illustrate is at the bottom here, CTEPH is actually fairly uncommon, around about 2 to 3% of patients with a pulmonary embolic event. But we know from lots of previous studies, from Eric Klock and others, that patients are pretty symptomatic following a pulmonary embolism, and maybe up to 40% of patients may present with some degree of breathlessness. So you've got to have some sort of approach to triaging your testing in patients following a pulmonary embolic event. So I want just to show you a brief case here. It's a 45-year-old man, complains of persistent breathlessness following his PE. You're seeing him at 3 months. His initial presentation was a subacute presentation with breathlessness. To help you, I put some arrows on there, but I'm sure you can see the presence of clot in a dilated right ventricle. And the question is, to the audience here is, you wish to exclude CTEPH, what imaging investigation would you perform in addition to echo? So would people perform a CT pulmonary angiogram, dual energy CT? Would you go on and do a conventional pulmonary angiogram? Would people do MR perfusion imaging? Or would people just do an old-fashioned VQ scan? So what sort of tests would people do here? VQ, CT. So I think there's lots of different options. I think why Q scanning has been traditionally recommended in guidelines is that the Q scan is very easy to interpret and we can see multiple perfusion defects. It's a really good rule-out test for chronic thromboembolic pulmonary hypertension. But we can assess for lung perfusion in lots of different ways. So some institutions will have access to dual energy CT, where we can also create perfusion maps. For people who don't have access to CT, you can use lung subtraction iodine mapping, where you can just scan the lungs, inject with contrast, scan the lungs again, and subtract the images, and you can get these perfusion maps. we're quite interested in MR imaging, and for over 20 years we've used MR imaging, 3D MR perfusion maps, and shown in a single centre it's just as accurate as nuclear medicine scanning. So what I'm saying is there's lots of different options in terms of lung perfusion. But many of us like using CT pulmonary angiogram, which is a fantastic test. But one of the challenges with CT pulmonary angiography with non-specialist pulmonary vascular radiologists is that some of the abnormalities of CTEPH are often quite subtle and can be missed. So there are some features, obviously, of CTEPH that we can see with a CT. So dilated bronchial arteries, for example. You can see the mosaic perfusion pattern that was highlighted in the case yesterday. You can see distal infarcts, and you can see attenuated vessels and webs. And I particularly find it very difficult sometimes to see some of the attenuated vessels, particularly when you've not reconstructed your images. So you can identify the features of CTED, but one of the challenges that sometimes people are less experienced may well struggle to do so. What I do like about CT, though, and I mentioned this earlier, is you can find features of pulmonary hypertension, big pulmonary artery, look in the outflow tract, that's why you see a compacted myocardium and right ventricular hypertrophy, look at your RV-LV ratio. But also importantly, on the CT scan, you can look at other problems. You can look at left atrial dilatation and left heart disease, and you can also look for coexisting lung disease. So these are important factors when you're trying to determine whether you want to perform further testing in any patient who may present with breathlessness. So in the guidelines, they do remind us that a proportion of patients will present with CTEPH with no previous history of pulmonary embolic disease. So we've got people presenting with unexplained breathlessness and pulmonary hypertension who may have CTEPH, but also people post-PE. And the recommendations are to perform a perfusion lung scan and echo, and when there are significant abnormalities, then refer to a PH centre, stroke, consider CT pulmonary angiography. So what do we do in Sheffield? So I work in a fairly bleak city in industrial England with a population of around about 600,000 with a much larger sort of urban population. So we run an acute PE clinic, and we've done this since 2010. So we try to see the majority of patients following a pulmonary embolism. So if you come into our institution, you will be diagnosed with a PE. You'll see a nurse after a week for cancer screening and systematic evaluation. Then you'll come to our PE clinic at 3 months. And what we'll do when you come to the clinic is we'll make sure you've had a pulmonary embolism. Probably about 1% of people, in fact, haven't had a pulmonary embolism. We'll phenotype the event, and then we'll have a good discussion about anticoagulation, lifestyle. But what we'll also do is we'll consider whether the patient has chronic thromboembolic pulmonary hypertension or not. And I'll go through our approach to how we do this a wee bit later on in today's presentation. So in real-world evidence, what's our experience of running such a clinic? So over a 10-year period in our institution, we performed about 20,000 CTPAs for suspected pulmonary embolic disease. There were around about just over 3,000 patients who were diagnosed with an acute PE in that 10-year period. And we saw nearly 2,000 patients in our PE clinic. So we see patients for a single visit, usually at 3 months. We decide whether or not to investigate or discharge. And we were able to, using that sort of fairly simplistic approach, have a diagnostic rate approaching 2% for chronic thromboembolic pulmonary hypertension. But what's quite interesting, if we look at our Sheffield pulmonary hypertension clinic, we identified 41 patients with CTEPH. We also, over the same time period, identified 32 patients in our £600,000 hospital referral population with CTEPH. Those patients tended to be younger than the patients we identified from our PE clinic. And we cover a population of nearly 20 million people. And over that 10-year period, we identified another 770 patients with chronic thromboembolic pulmonary hypertension who referred into our centre. And what's really interesting, if we look at our Sheffield PE clinic, we can see that patients had more modest pulmonary hypertension, MPAP 37, PVR 4.6 Wood units. Quite interesting that our Sheffield suspected PH and non-Sheffield suspected PH had much more significant hemodynamic disease with PVRs of 8 Wood units. So instituting such a pulmonary embolic follow-up clinic can actually help you to diagnose patients with chronic thromboembolic pulmonary hypertension slightly earlier than traditional approaches. And what we found particularly interesting, if we look at our city in Sheffield, we've got much higher diagnostic rates for that population of around about 13 per million per year compared to 3.6 to 5.2 per million per year for patients who are in our referral population, which is very similar to the UK diagnostic rate. So having such a clinic and approach, fairly simple, dumbed-down type of clinic, where you do very much a symptomatic assessment, can aid the diagnosis of PH. But what is quite interesting is quite a lot of patients who are obviously less limited elect not to undergo surgical intervention. So again, with BPA, there may be an opportunity to offer these patients other therapies. What's a really important aspect of that clinic is reviewing the initial CT imaging. So when we look at the CT imaging, we identified 41 patients. We had CTs available for 36, and we had a sort of matched control group. And we can see here that for patients who didn't go on to develop CTEPH, you can see around about a third of our population have got a dilated right ventricle. It's fairly uncommon to see features of chronic thromboembolic pulmonary disease, and we can see here that a few patients did exhibit those characteristics. But you can see here, if we look at the features of pulmonary hypertension, if you've got the full house of a dilated pulmonary artery, RV-LV ratio greater than 1, and outflow tract hypertrophy, it greatly increases your risk of going on to develop CTEPH. So patients who've got features of an intermediate risk or intermediate high risk P are more at risk of going on to develop CTEPH. And again, you can look at those initial scans and actually identify features of pre-existing CTEPH. So another interesting finding from this study is that if patients have no major transient risk factors, so unprovoked P, they're much at higher risk of going on to develop chronic thromboembolic pulmonary hypertension than patients with a major transient risk factor such as surgery. So using these types of risk stratification approaches can help to refine your approach in terms of who you wish to investigate. So when we try and look to put it all together, what do we do when we are assessing our recovery following acute PE? Well, one of the very first things that we do is we assess for breathlessness and also risk factors for CTEPH, and also the presence of comorbidities, which may refine which patients you want to investigate. It's just to remind you that a history of recurrent PE is a clear risk factor for developing CTEPH. Having no major transient risk factors very significantly increases your risk. And then there's some other aspects in the history, splenectomy, pacemakers, thyroid disorders are all features that make chronic thromboembolic pulmonary hypertension more likely. I like to very systematically look at the initial CT pulmonary angiogram, look for features of chronic thromboembolic pulmonary disease. Are there any bronchial arteries enlarged? Do you see the presence of webs? Are there attenuated vessels? Is there calcification in the pulmonary arteries? Is there a mosaic perfusion pattern? Look for features of pH. But also, I always draw around the left atrium. Have you got an enlarged left atrium? Do you have evidence of underlying lung disease? And also looking at that initial echo. If your echo initially shows a systolic pressure much over 50, TRJ over 3.4 meters per second, you're at increased risk of having CTEPH when you present, because acutely you can probably only generate a systolic pressure around about 50, 60 millimeters of mercury, absolutely tops. What's really important, I think, when you see patients, because many people are frail following a pulmonary embolism, got other ongoing problems, you have to make the decision whether you feel the patient is likely to benefit from further intervention. If they are, I'd assess for chronic thromboembolic pulmonary disease using perfusion imaging. So you can use nuclear medicine imaging, you can use MRI imaging, but many people use CT pulmonary angiography, and there may be particular reasons you might decide to do a CT pulmonary angiogram. There might be an abnormality in the lung like a nodule, but just remember you can miss CTEPH. We assess always with an echo as well. If I'm suspicious, I do the two tests together. You can, if you wish, do lung function tests, and remember that gas transfer factor measurement. And then if there are perfusion risks, or the patients are at intermediate risk or high risk from the echocardiogram, what we would recommend to referrers is to do a CT pulmonary angiogram and then refer the patient on to us if they wish to do so, so that we have all that information available for external referrals before we make a decision whether we want to investigate further. And if there's no evidence of you've got reassuring echo symptoms, no perfusion defects, then when we discharge the patients from the clinic, we always tell them in the future, if they're breathless, then to seek medical advice. So that's a very practical approach to how we manage patients with pulmonary embolic disease. I should also say doing a joint clinic with a haematologist is quite good fun. We normally spend the first 20 minutes having a bit of social discussion and a coffee. So what about moving forward? Some people may not feel confident looking at CTs, but the more you do it, the more confident you become. But we can now totally and absolutely segment the large vessels, cardiac chambers, and we can see here we've got an automatic segmentation tool where we can start to look at degree of hypertrophy, volumes of the different cardiac chambers. And you can see this patient here has got quite extensive thromboembolic disease. So we can now start to automatically quantify things on CT. And we can also look and we can see mosaic perfusion patterns here. And we can teach AI to recognize these different patterns. And this is some of the work that my colleagues Andy Swift and Sharkey and Lo Jane, who's here, was one of our PhD students who's now come back to Jeddah, was involved in some of this work with AI. So what we do struggle, I think, with often is identifying thromboembolic disease. So again, you can see on the left here the same patients, but we can use AI to start to flag up where all these different clots, different types of abnormalities are present. So this has taken many years and it's not perfect, but I think we probably will start to move to a much more automated approach to identifying chronic thromboembolic disease. So we can now sort of segment the lungs, look at the large vessels, look at cardiac chambers. We can also start to look at vessels, and again, Lo Jane was involved in this work. We can start to extract the arteries and the veins, and you can see here on the right-hand side a CT scan in a patient who's got fairly unilateral looking chronic thromboembolic disease. So I think imaging shows a lot of promise. So I'm very interested in cardiac MR, not as a radiologist, but as a tool to make my life a little bit easier. So we've done a lot of MR perfusion imaging, and you can see a very old MR angiogram. But what I think is really important with new technologies is that we do clinical trials, and we discussed earlier in lung disease the importance of clinical trials of drug therapies. But I think we have neglected clinical trials of radiological investigations. And this is just really a shout out to Jens Vogel-Clausen, who has now conducted, we're involved in this study. It does look a little bit of a sort of European Dad's Army map. That will be a reference that only a few people in the audience will appreciate. But we're working very, very closely together as a large group, and we will be able to unravel what the pros and cons of all these different imaging modalities are. And we've enrolled around about 1,000 patients. So in conclusion, CTEPH is an uncommon but important complication of pulmonary embolic disease, and of course people like Hiromi here have really moved away, not away from surgery, but giving us alternatives which are potentially much more appealing to our patients. For me, one of the most important things is not doing lots of fancy tests in very highly selected patients. It's having these integrated pathways of care, which I think are important in diagnosing chronic thromboembolic disease, and also giving lifestyle advice and deciding on anticoagulation. I hope I've shown you that having a systematic approach to following up PE, which everyone in this room can reproduce, improves diagnostic rates of CTEPH and identifies milder disease. And I think really for people in the world of pulmonary vascular disease now, I think all these advances with imaging technology and AI will make a big difference. And I do particularly just want to give a big shout out to our large team in Sheffield. We have four hematology doctors, thrombosis experts who do the work with us. And I've shown in bold here just one of the values of collaboration and going to meetings. These are 3 current or previous PhD students. So Turki Al Nassar did a lot of the segmentation work that I showed in non-enhanced CT. He's in Sheffield just now from Saudi Arabia doing his PhD. Lo Jane is in the audience here, did a lot of work with the segmentation with vessels. Faisal did a lot of work with cardiac MR. And Sarah was involved with Alex Rothman and published a paper in Cell, and she'll be coming back to Jeddah as well. So I'm very grateful for the collaboration with our colleagues in Saudi Arabia. Thank you very much.
Thank you, Prof. Kelly. You can join us on the stage.
So it's my great pleasure to introduce the last speaker today, Dr. Ali Abu Saud. Dr. Ali Abu Saud is Associate Professor, McGill University, Montreal, Canada. He is a cardiologist, interventional and structural heart disease. He's also an adult congenital heart disease at King Fahd University Hospital, Al Khubar, Saudi Arabia. Dr. Ali, the floor is yours.
Thank you very much. Bismillah ar-Rahman ar-Rahim. I do have a severe case of imposter syndrome here. Like I really am sharing the stage with like unbelievable legends, as it was called. And I really thank the organizers, the scientific committee, for giving me this chance to share a little bit of our experience in the eastern province of Saudi Arabia. Sorry, just... Oh yeah, sorry. So I also don't have a huge pharmaceutical list of companies. Unfortunately, I have no financial support yet, so I'm open. I am not a pulmonary hypertension specialist, but I consider myself an enthusiast. And I'm an interventional cardiologist, so I really like BPA. I don't know how to operate this. So, just briefly, sickle cell disease, as many of you know, it's an autosomal recessive genetic disorder affecting the beta globin, where there's a replacement of glutamic acid to valine. That makes these cells prone to changing in shape of a sickle or sickling or breaking down with hemolysis. It is a multisystem spectrum of disease. It actually has a multiple proposed pathophysiologies of how it affects various parts of the body. There's the hemolysis and causing the endothelial dysfunction, consumption of NO, etc. There's the sickling and the occlusion, which is the viscosity. So when you look at the decreased NO bioactivity, it causes pulmonary hypertension, leg ulcerations, priapism, strokes. If you look at the vasoocclusion, it's the painful crisis, the acute chest syndromes, osteonecrosis, etc. But the mechanism of sickle cell and PH is way more complex, and I won't go into details, and there are much better people talking about this than me. But there's the hemolysis itself, there's the oxidative stress, there is the increased vasoreactive mediators, splenectomy or autosplenectomy that happens, coagulation. I mean, we know that it might happen either thromboembolic or in situ, the hypoxia that they get, and there's also probably some genetic susceptibility. It was historically considered type 1, then it moved to type 5 or group 5 PH. Unless there is chronic thromboembolism, then it becomes a group 4. So I looked at the prevalence of sickle cell disease in Saudi Arabia, and if you look at the eastern province, I don't know if it shows, but that's where I come from, and about 1.45% of the population, 1.45% of the population have sickle cell disease, and 17% have sickle cell trait. And I'll just disclose that actually my father has sickle cell disease, and I do have sickle cell trait. So it really, literally hits home. If you go to the south, it's 0.24%. The west has 0.12%. Riyadh about 0.06%. But nationally, it's about 0.25% with 4% of sickle cell trait. So it is really quite prevalent. In terms of the prevalence of PH in sickle cell, there are various reports by echo or TR velocity. About a third of patients with sickle cell do have the range of PH, but invasively, taking the definition of 25 millimeter mercury or PVR more than 3, it's, I think about 10% is the number that we came to. I looked at local reports, it's variable, only echo, no invasive, and it ranges anywhere between 37 and even up to 80%. All that to say, it's a lot of PH happens in sickle cell. If you look at thromboembolism, in this very nice paper, it actually, by the age of 30, patients with sickle cell disease would develop PE, and by the age of 40, over 10%, 11% would develop PE. Interestingly, the incidence of DVT is much less than PE, which also supports the theory that might be more in situ thrombosis rather than it being thromboembolic. Of course, once you develop, or sickle cell disease patient develop VTE, then the mortality also increases, as well as when they develop PH. If you look at this group of patients, not a very big group, and I won't go into details, but when looking at patients that have PH by echo, the VQ scans were predominantly either low probability PE or intermediate or high, so a very high prevalence of abnormal VQ scans. And if you had an abnormal VQ scan, the higher the likelihood, the higher the pulmonary pressure was. Another paper looked at 142 sickle cell disease patients, showed 46% abnormal VQs, various abnormalities, but 46%, including also, maybe interstitial lung disease or like lung disease problems, but still significant amount. And CTPA was positive in over 25% of those patients. And looking at the graphs there, once there is a abnormality in the VQ, then the cumulative survival would decrease significantly, and then not comparing patients that develop PH versus no PH, the survival is very, very different. This is a very nice paper by the French group also. I didn't want to go into a lot of details about the subtypes of sickle cell, but they took a total of 58 patients. This is the total of 55, but if you take the sickle cell SC disease, there was 85% chance of having segmental defects. And those are the ones that really have DVT-PEs and very classic CTEPH. If you look at the SS or SS beta thal, which is what we probably have in the Eastern Province at least, or mostly in Saudi Arabia, about segmental defects are about 9%, but still the heterogeneous perfusion was in 50%, and the normal ones were really less than 40% or so. So just looking at it from a big picture, I mean, 1.4% in the Eastern Province, over 10% incidence of PE, with over 10% PH, the CTEPH incidence must be higher than what we think. Unfortunately, also in that area, we have limited access to VQ scans, limited access to right heart cath. Medical therapy for sickle cell disease, hydroxyurea made a lot of difference for these patients by increasing hemoglobin F and less complications. There are new therapies that are up and coming for the management of the disease. But in pulmonary hypertension, all we have is generally riociguat. I would say all, but like maybe the one that we comfortably give is riociguat, and that's really based on the study of 6 patients only. Looking at endarterectomy in sickle cell patients. So, I mean, we already know that endarterectomy is not an easy surgery. It's a complex. The bypass time is long. It's a complete circ arrest. There's hypothermia in there with acidosis. And patients with sickle cell disease really do not tolerate these things. So managing them by doing exchange transfusion before and whatnot has been successfully reported. And if you look at all these studies there, they all have like one patient, one here, 2 here, one. So very few, but I mean, it's been demonstrated that it's being done successfully. Disease location, very important in those patients, and I think a big limitation to endarterectomy as well. Not to mention the post-operative complications of whether it's acute chest syndrome, vaso-occlusive crises, strokes, and acute thrombi. So what is there for BPA in sickle cell disease? This is the largest data, and probably the only data that really is meaningful, presented at I don't know if it was ERS or I think it's OPVRI, by the French group as well, looking at 14 patients. But if you look at those 14 patients, 10 of them are the SC, which is the classic CTEPH, and only 3 had the hemoglobin SS, and 1 was the sickle cell beta thal. But in their series of 14 patients over a period of 10 years, it showed that they had relatively the same outcomes, same complications. So what is our local experience? And again, this is very recent. I actually joined December 2024 in the eastern city of Khobar. Hopefully maybe 2028, we would consider hosting you there. I'm in King Fahd University Hospital, part of the Imam Abdurrahman bin Faisal University. And there we did our first BPA January 8th. This is our CTEPH list at the moment, about 14 patients. 7 patients of them are sickle cell disease, which is 50%. 23 BPA sessions have been done so far. 15 of them were in sickle cell patients, and 3 are undergoing a workup. So I'll just mention a representative, or maybe we'll go over our cases, but this is one of the first cases and my brand new experience with sickle cell disease. So 37-year-old female, sickle cell disease, beta thal, frequent admissions for vaso-occlusive crises, about 6 times on average, once every 2 months. Had her first acute PE 7 years earlier, was on riociguat for 2 years. WHO functional class 3, uses her HOMO2 from time to time, can't travel, can't go far. So echocardiogram, severe RV enlargement, RVSP measured about 52 at that time. VQ scan, I don't know how it shows, but even though they said mottled heterogeneous appearance in both lungs with variable size perfusion defects, differential was peripheral arterial vascular stenosis, pruning, maybe vasculitis, maybe CTEPH, but I would buy that that VQ scan is actually consistent with CTEPH. She had also, by one of my colleagues prior to joining, so it was not digital subtraction, I tried to just like mimic it, but very difficult to draw conclusions, but she had severe pulmonary hypertension, systolic 92, mean of 53, low wedge pressure, cardiac output was high, PVR measured around 6.7. They said peripheral pruning, no clear evidence of CTEPH. But I took her back based on the VQ scan with selective angiography. And if you look at you know, the bottom there, like very far, we're talking about like, this is A5, segment, subsegment, sub-subsegment, there is clear disease that is suggestive of CTEPH. Moreover, I don't know how it shows, but you see where the wire is, and if you look at that catheter is 2 millimeters. And look at the size of the vessels distal to it. And I'm far, and I'm, you know, poking with the balloon, the wire. But we actually managed to recanalize certain, you know, segments. More, just another example of how you have the subsegment and you have like 4 different branches, subsegment, and you have to enter in each one of them, 1, 2, 3. So instead of like opening one segment and then you recruit the whole segment, you actually go into subsegmental disease and you chase it. It also goes with, like even when you open it, there's still distal disease. Also, in my opinion, supporting the theory of a lot of in situ thrombosis that's happening there that you're trying to recanalize. And it does work. I mean, there is more flow, but it just unveils more distal disease as well. So, you know, sometimes it's difficult to draw the line. But looking at her baseline and what happened after 2 BPAs, I was really not optimistic. I thought I'm doing this just to induce hemoptysis and perforate. But her mean pulmonary pressure, and that's after years, she's not like up and down patient. It really had this severe pulmonary hypertension. It shockingly normalized with normalization of PVR, and she's off her O2, and now the riociguat is being weaned, which I'm not very keen on, but the person who's following her is doing that. Echo normalized, BMP normalized, and she's functional class 2. Another patient, 34-year-old, sickle cell disease, also recurrent crises, on riociguat for 3 years, but has been having also symptoms for a long time. HOMO2, he came to me, or came to us from far away, but he has very nice, you know, like CTEPH, proximal, you see where the lesion is, can go comfortably with big balloons, open, recanalize, same thing here on the upper lobes, nice. If you look at poor angiogram, but like this is A10, very big segment, very osteal kind of stenosis. So I'm happy that I will do this, but once you open and you go further, he also has like much more disease distally as well. So you're just chasing that disease everywhere. And he has like everywhere else a lot of like mixed distal. This is his as well. Look at I'm very far, almost in the pleura there, and then you have your subsegmental, very small disease. And look at the balloon, the waist of the balloon. That's where the lesion is, and then pop, it pops up. I mean, you hope that you didn't pop up the artery as well. But then you look at it, and it opens, and it looks decent. But for me, at least, it's very difficult. Takes like very time-consuming. I did 6 BPAs for him, trying to normalize his pulmonary pressure. But the mean pulmonary pressure is still about 35. Interestingly, baseline, his wedge is high. Unlike the other lady, his wedge is 18. Cardiac output about the same. PVR did drop though. Saturation did improve, but he still has like the dilated RV and the RVSP of 60. Improved functional class though. Another one, just also every month he's in the hospital, had hip replacement for avascular necrosis, infected. They didn't want to touch him because of the pulmonary pressure. But he had, again, decent location disease. Okay, I'm happy, I'm going to go after it. But same thing. You go to the other places, like very, very far disease. Improved symptomatically very well. I only did one, so I don't have the follow-up hemodynamics. 38 on HOMO2, same thing, decent disease in very decent locations. So this is more consistent with like just distal CTEF, but not like microvascular. I'll share with you, this is the last, like patient number 5, 47-year-old lady who's been very sick for a long time, came in anasarca, RA pressures like over 20, really, about to die. And interestingly, she has very classic CTEF. I mean, this is usually would be a surgical disease. It's very segmental. The surgeon would go clear up, but she was just like too sick to be transferred anywhere. I said, okay, I'll do my best. And then we do 2. The A3 opens up nicely. A2 opens up nicely. I don't have the A1, but very happy with how things are going with her. She had very bad hemodynamics, pulmonary pressure of 100, mean of 60. Cardiac output, on PVR was 9, severe RV dilatation. I say 1.5 BPA because we had a technical failure as soon as I started the second one, so it was not complete. But when I brought her to the third one, a bit of improvement, but still, again, wedge pressure, 19 and remained 19. Cardiac output improved dramatically. She felt much better, PVR dropped. O2 sat much, much better, didn't have an echo. And functional class improved. She was actually so happy she left the hospital off O2. So, and I'm very proud that I've saved the life of this patient who's been suffering for like 11 years. Only to hear just earlier this week that after she left the hospital, a week later, she passed away. And I tried to investigate him. She's in 2 hours away. She went into a small hospital with painful crisis. They said she was doing fine. They're talking to her. All of a sudden, overnight, huge deterioration. And they just, they told her the lung gave up. And I'm not sure what exactly happened. The only thing is that she was never on Riociguat, and we started the Riociguat, before 0.5. I don't know if the output of 7+ was contributed. I have no idea. I'll try to get more information. But certainly it was painful, to hear. So what were the complications that we faced? Hemoptysis, we had very mild hemoptysis, once balloon tamponaded. Interesting, and I've never expected this, almost 90% of those patients develop painful crisis within 24 hours. And I still am trying to explain it. Is it the stress of the procedure? Is it the temperature in the cath lab? Is it the length of the procedure? Are they dehydrated, NPO? Is it their hemoglobin S level? So my approach generally, and I use the Okayama style BPA, is that I have 60 minutes of fluoroscopy, 125 of contrast, or like 250 total diluted, and I do what I can in that session. Is it too long? Should I just 2 segments at a time, shorten it, make it simple? Because the other alternative is doing exchange transfusions that you do for surgery, but to do that before every BPA is almost, impossible. But hopefully I will have a little bit of a better explanation or like way of mitigating that the next time. The median stay, I usually bring them the morning of 24 hours, they leave. For sickle cell disease, they end up, getting stuck there for days. So my summary, at least what I, understood from all this, is that CTEF in sickle cell disease is likely under-recognized. Is possibly mostly in situ thrombosis, maybe more than thromboembolism. And I think it depends on the phenotype and the subtype of sickle cell disease. Is there chronic hemolysis-related vasculopathy on top of that? I think that BPA is likely effective in sickle cell disease, but it's certainly more complex and possibly a higher risk procedure. But I also have more questions about it. So does improving the oxygen saturation, we've clearly, demonstrated in this like small number of patients, reduce the chances of vaso-occlusive crises? And it's likely not, because the same patients that I follow and call them to come back, they're in their same, like, oh, they're in the hospital here, they're in the hospital there, so I don't know if I got that. 2, does it really reduce the mortality like we saw the 10-year survival in this patient population? I don't know. Is it mostly in situ or thromboembolism? Is it a different approach? Where does the acute chest syndrome, which we see quite often and I don't know what to do with, and should we consider anticoagulation, even though it sounds crazy, but if you look at 10% of patients with VTE or like PE, is it really crazy to give them that? And of course, nothing would happen without having a team behind me. And I'd like to thank them, both my Canadian team and the team in Saudi Arabia. But I also would take, and I really appreciate, I got 5 minutes extra in my session for some reason, and I'd like to acknowledge someone. First of all, again, thank you to Dr. Abdullah, Dr. Hassan, for the organization, for the scientific committee, for the distinguished speakers. It's the first time that I think I really earned all the CMEs, because I did not miss a session. I enjoyed this meeting so much. But also, like someone in particular, and I will just take you very briefly to my personal journey, and this is really personal for me. So in September 2017, we had a young patient, 17 years old. Her name is Roxanne, had severe CTEPH, went for an endarterectomy. Very complicated, didn't really go well, 3 weeks in the ICU. So I don't know if you know, so I worked with David Langleben in Montreal, and he says, Ali, you have to start doing BPA. So of course I'm very excited. I was like, yeah, for sure, but what is BPA? At that time I had no idea. So he arranges for me to go and see the legend, Dr. Hiromi Matsubara, in Okayama. So I spent 2 weeks. One of the probably best experiences in my life, but probably the highest impact on my career was, I did 10 years of training. Those 2 weeks were just very different. Learned a lot about BPA, anatomy, angles, equipment, techniques, complications, and most importantly, as important as BPAs, was food. So after I finished those 2 weeks, Dr. Matsubara comes to me and brings a hard drive and put it in my laptop. And he gives me this wealth of talks, educational material, pictures, videos. And he says, so I'm very appreciative, like I can't believe you're giving me all of that. He said, I ask for one thing, do a good job. So I'm not finished. So I went back to Montreal. I was like, he will not know if I'm doing a good job or not, but we'll see. I was very skeptical, I have to say. 2019, just coincidentally, Roxanne, the same patient, Dr. Matsubara had a visit to Montreal. And I told him, I have a case, so do you want to join me? And of course, he joins me, and we do the case together. And I say, after we finish, I say, I hope she will improve. And he looks at me and says, of course she will. So, sure enough, those were hemodynamics at her baseline, and she was really one of the first that we had exceptional results, normalized her PAP's normal life. So then after 2019, I'm looking forward to going back to Japan. I had a great time in there. I really want to. Pandemic hits, I don't. So what I end up doing is I built my own Japan in my house. This is actually in my attic in my Canadian house, where I had this mini, model, until I was able to go back in 2023 to visit Okayama again. And I truly, now I know the procedure. It's been 5 years. I've done quite a few procedures, and I went, and it's like, now I realized how unbelievable the skill, the efficiency, the experience that they have. They were way ahead of everybody else, and that really, the 10-year experience really made a lot of difference. So now I appreciated them even more. But I'm also coming back, and I'm telling him, I'm so excited to tell him how good of a job I've done in Montreal, and I'm excited, and that's where we were the first day. And he says, it is very important to be humble. So I stopped talking for the rest of the week. So the last thing I would like to say is, Watashi, Canada to Saudi Arabia no shitefu no kanja oda yoshite 本当にありがとうございます。Thank you very much. Thank you for the time as well.
Thank you, Dr. Ali. Now we will open the floor for questions. Dr. Faiz.
Assalamu alaikum. Thanks for the speakers. Really great session. So my question to Dr. Ali Abu Saud, for the distal disease in patients with sickle cell, how would you differentiate between true pulmonary embolism versus the obstruction related to sickler itself?
I was hoping that someone will teach me here how to do it. I would think that maybe doing intravascular imaging, OCT, but it's also too distal. They're too small, and I didn't feel confident enough to do that, but maybe that would be part of it. I don't know if, based on the angiographic finding of Dr. Matsubara, this is just classic CTEPH. Is it something different? I honestly don't know. Certainly, it behaves like CTEPH, and I think there's a role for ballooning it as well, but I honestly, I don't know.
Yeah, that was my second question. Would you do BBA procedures for those cases?
Well, I already am.
The distal ones.
Well, they're all, I have yet to see someone without distal. Like they all, if you look deeper, there's always some. And I don't know. I really, the more, at least from my experience with those 5 patients, I think that the recurrent vaso-occlusive crises or just the stagnation will create some in situ thrombosis at varying levels. And some will resolve with that really at the microvasculature or like just distal, the small branches. Would it just look different than it is in the segment or subsegment or a 2 millimeter vessel versus a microns vessel? I honestly don't know. Is it just a look or is it really histologically different?
Yeah. Thank you.
I'll go to Luke. Go ahead.
Really enjoyable session. We have, I don't know if you know the term oxymoron, but a humble interventional cardiologist is probably a definition of an oxymoron. But anyway, it's nice to meet one or two of them from time to time. And honestly, great presentation and congratulations on your work. I've got 2 points really. The first is that we know from the walk-fast trial from many years ago that sildenafil causes vaso-occlusive crises. So, the advantage of getting the pressure down may be that you can then withdraw. I don't know if riociguat has the same potential side effect of vaso-occlusive crises as sildenafil, but that may be an advantage of the intervention, such you can come off at perhaps a higher threshold than you would in non-sickle. So that's a point. And then a question is, do you see a different distribution of disease in sickle in terms of where you're doing your angioplasty? I mean, I'm not very good at getting my orientation right, but you seem to be doing a lot of upper lobe vessels. And I know that in the UK, where perhaps they're slightly less aggressive, they're only really interested in the lower half of the lung. So, are you seeing a different distribution of disease, perhaps because some of this is in situ? So, sorry, 2 points in there, and congratulations again.
I appreciate it. Great questions. In terms of the distribution, I don't think that, no. Maybe I was very selective in the angiograms just to show very clear pictures for the audience and see what I'm talking about. But I, first of all, think that most of the time when you reach significant pH, you've burnt out you've plugged in most of your segments. So everywhere you look, you'll probably see at varying degrees. Is it, I don't know if more about smaller vessel disease would be in the lower or upper. Honestly, I don't think I have enough volume to be able to appreciate that, but not clearly. What is very evident for me is that unlike a usual CTEPH, is that you would dilate one and maybe first bifurcation second, but here I'm dilating as I go in. I'm digging almost like recreating the tunnel until I open the distal part and then the rest of the vessel opens. So but in terms of distribution, I'm not sure. In terms of the, yes, I think the question was the PDE5, like the sildenafil, and I still wouldn't know, I don't know why that would. Interestingly, I mean, there was a patient that, came back after the first session, said, I wish I can take my eyes and give them to you. Okay, so so happy. The second session though, she was very disappointed. Like, I did very well, but she's like, she feels a little bit worse than the second. And I don't have an explanation to that. And as I'm reviewing everything and putting the data in, and is there a happy medium? Like, instead of, because I'm used to just overdoing it, and when you mentioned between the lower and upper, I just do like Japan, I would start A10, A9, A8, I would just systematically make my way from bottom to top, one lung, and depending on how much time and ease of crossing. But in this particular case, I don't know, did I overdo it? And that's why she felt, worse? I don't know.
Well, I mean, some of your patients, they've all got the complications that we see in sickle with the high output.
Yeah.
And it may be that there's just that sweet spot where if you open too much, you overload the LV. I'll hand on the mic.
No, that's a great point, and I hope I will have an answer in the near future. But thank you very much.
Yeah, we'll move to Ahmed.
Thank you very much. So I have two simple questions, actually. We are getting much better in diagnosing and suspecting, diagnosing and treating CTF. However, and I understand the prevalence is quite low. Are we doing anything to prevent it? Do we know how to prevent it, for example? Is it constant incidence after PE, still same 3.4 or whatever percentage we have?
I mean, I think it's a great question. It'd be nice to be able to intervene early in someone who presents with an acute PE to prevent the development of CTEPH. I do wonder if one strategy that might be beneficial is we are moving much more now to very carefully selecting who we place on long-term anticoagulation. So we know that if you present with no major transient risk factors, you probably have a 1 in 4 risk of having a PE over 3 years again if you stop anticoagulation, 1 over 10 years. So I think you can hypothesize that with a more aggressive approach to long-term anticoagulation, many patients at a secondary prevention dose, that you may prevent further embolic events, which then may well prevent the development of CTEPH in the future. Certainly in our experience, where we've run this clinic, we've now seen over 4,000 patients since 2010, that we haven't had a lot of people who we've seen in the PE clinic come back later on with a diagnosis of pulmonary hypertension, but the proof will be in the eating of the pudding. But I would expect with a more aggressive approach to long-term anticoagulation will prevent further events in the development of CTEPH. And we don't see in our clinical practice the patients I used to see in the UK over 20 years ago who presented with very extensive thromboembolic disease proximally with lots of calcification. I think we are getting a bit better at diagnosing CTEPH earlier.
Second quick question, compared to the usual CTF, did you see any recurrence for these patients after ballooning? Especially, so for example, you bring them for 2 sessions, 3 sessions, did you see some of the vessels, they open, closed again or something?
Yeah, so I was almost confident that I will see reocclusions because I was really not confident of the work I'm doing. It was actually the opposite. Most of it was really much better than I left it. I have examples of you dilate very small vessels next time they come in, which is like regular CTEPH, just a big segment open up. So no, I don't, but they're anticoagulated. So overall, I think it's the same. Thank you.
Thank you. It was truly a great session to end SAPH this year with it, and a great talk, Ali. With you thank Dr. Matsubara on behalf of all of us in his own language. That was very nice. The question to you, Hiromi. Now, very impactful and very impressive data, the 10-year survival, the hemodynamics, both in your center and in France as well. So, and this is also a continuation to the last question. Have you ever found a difference in the background of patients in terms of recurrence of the occlusions or the response to BBA, particularly autoimmune disease and particularly antiphospholipid syndrome, because they behave differently?
Thank you.
So the recurrence, true recurrence, not just increasing the peer pressure, but also have newly developed regions. We have experienced only 2 among more than 500 cases. And those 2, one patient stopped using VK, and one patient taking the low dose, half dose of edoxaban. So in both patients, the anticoagulation almost stopped for, I think, several months. So after that, recurrence. So even after completing the treatment, the lifelong anticoagulation should be considered and should be sufficient amount of the anticoagulation would be used.
And I'm going to ask the same question I asked Irene before. Do you think, based in your data, it was clear that the PPA is becoming really very high in terms of numbers compared to PEA? In your practice, do you think it's truly taking the place for patients who were one time considered to be PAA patient, and now because of more advanced techniques and PPA, the procedure is now considered for them rather than surgical procedure? What is the gray area here?
So personally, because officially I cannot say about that, but personally, from the situation in Japan and South Korea and in China, before starting BPA, the number of PEA much greater compared to the patient treated by BPA. But nowadays, for example, in China, there are patients are 50-50, the male, female, and mainly proximal region, whereas 80% of patients treated by BPA. In Japan, the 80% female, 20% male, a bit different, and mainly the distal regions, and more than 90% of patients treated by BPA. South Korea also, like China. So probably in the future, not near the future, but in the future, the situation would be changed.
So I have the last question probably before we conclude to Prof. Kelly. We always do VQ scan to rule out CTEPH, and when it comes negative, that will be great. But sometimes it's positive, and then when you do CTPA, it's negative despite the high likelihood that the patient has CTEPH. So how would you approach those patients? Would you go to a lung MRI, or how would you approach them?
So the question is, you have an abnormal Q scan, but a normal CT pulmonary angiogram. I mean, I think my answer to that question, if it's a good quality CT pulmonary angiogram with an abnormal Q scan, I think clinically significant chronic thromboembolic pulmonary hypertension is fairly unlikely. There are lots of reasons you can have non-specific perfusion abnormalities as well on nuclear medicine imaging. You can often see abnormalities also on the CT. So I'd be very surprised for someone who's got an entirely normal CT pulmonary angiogram. I wouldn't feel there was any need to perform any further diagnostic tests, but I think you want to make sure that the CT pulmonary angiogram is normal. That would be the caveat.
Perfect.
Sorry, I will make an exception. So, Prof. Gofrani, sure, go ahead.
Can you hear me? Yeah. So thanks for giving me the opportunity for the last question. Referring to the discussion between Dr. Abdallah and Dr. Matsubara, I didn't want to leave the final comment unopposed, because as much as I believe that BPA has changed the world of CTEPH, and thank to Dr. Matsubara for spearheading the development here, the question whether or not to do PEA or BPA or maybe both should always be discussed in a multidisciplinary team. And if patients are clearly candidates for surgery, depending on the availability of a high volume program, obviously, the PEA should be preferred. Having said that, that's the problem of PEA. We only have a handful of centers that do more than 100 PEAs a year. And coming from a place where we do 150 per year, I can just tell you that we still follow the usual order. If the patients are technically operable, they will undergo surgery. If they are borderline, they may get even a hybrid intervention. If they are subject to a PEA and have recurrent or persistent pulmonary hypertension, they will receive subsequent BPA. This can only be done in high volume programs if you have acceptable morbidity and mortality associated to the intervention. If that is below 3%, which it is in most of the high volume PEA programs, I don't think there's a discussion that PEA should be preferred. The problem with the surgery is that the learning curve is very flat. It takes decades to master this surgery, as opposed to PEA, and we heard from Dr. Ali his impressive own career in BPA that can go much more steeply depending on the teachers you have. I think we will see an evolution of BPA anyway, but it shouldn't preclude patients from surgery if they have access to a high volume program, just as a comment. Thank you.
Thank you so much. I think now it's the time to conclude the session and conclude this fantastic conference. I'll ask kindly Dr. Prof. Dran to provide his closing remarks.
Thank you.
Thank you so much. Thank you. Amazing. Ali, amazing work. شكرا دكتورة. شكرا. Well, now it's time to conclude. I would like to thank every one of you for sticking to the last minute for this extensive 3 days program. We think we covered all important aspects of pulmonary hypertension in those 3 days. You have been receiving talks from the mouth and the brains of those who have contributed all their lives for pulmonary hypertension. So that extend my thanks to them again, and thank you so much for being loyal with us. Our international collaborators, Dr. Ghofrani has been with us, I think, for 17 years from the 19 years. So special thanks to you because you've been very loyal to SAPH, but also for everyone who has been contributing to the wealth of knowledge in SAPH for many years. Thanks so much for my colleagues in SAPH and those who also chaired the session and those who gave talks from Saudi Arabia, from the region around us. And thank you so much for the pharma industry who made SAPH happening over the last 19 years. So thank you so much. I have been thanking you for the last 3 days. And Hassan is asking me every day to thank you, so I'm doing that on his behalf too. Obviously on behalf of SAPH board members and members. Thanks to the audiovisuals, you've been very technically great. Thank you so much. The audiovisual was really perfect. Thank you so much. Now for SAPH next year, it's going to be in Riyadh, and it's going to be moved a bit earlier. It will be in mid of January because Ramadan is also moving this way. So it will be for 3 years, about 3 years in mid of January, and then we'll go back to our original dates. And it's going to be our 20th anniversary this coming years. Inshallah, we'll try to make it special. We will, it's going to be in Riyadh, and of course, throughout the year, you will be receiving update emails. Thank you so much, and have a safe trip back home. And we have a lunch that is provided in the lobby downstairs. Please enjoy your lunch before you travel. Thank you.